This is Sophie. She just turned 45. A wife, a mother, a daughter, a friend, a teacher. She is many things to many people. She was 17 when she first met her partner. 28 years and 3 children later, they still look at each other the same way as the day they met. Every summer, they go to the countryside cottage of Sophie's parents, in a hope of a quiet escape from their busy city lives. And maybe it would be if it weren't for all the cousins and siblings, and their families of course, all trying to escape the city buzz. Many of Sophie's friends, even from high school and university days, have been visiting for years. It is probably her unconditional love for people and passion for art that brings people together. She always says, "I am lucky because my passion is what I do." Over 20 years as an art teacher, she has inspired and touched the lives of many. It's only recently Sophie has been feeling like something isn't quite right. Today, Sophie was diagnosed with breast cancer. Breast cancer doesn't only affect those who are diagnosed with it. It has an impact on families, communities, and our society. Every 20 seconds, someone is told they have breast cancer. So Sophie may be just like someone you know. One diagnosis, hundreds of lives impacted. Treating breast cancer early may provide the best chance of cure. That is why we are committed to bringing every single patient with breast cancer closer to cure. And it is this commitment that drives us every single day.
Torrent Pharma, one of India's leading integrated pharma companies. Torrent Research Center works zealously in the quest to discover better therapeutic solutions. Have to their credit novel drugs that have been developed for the first time in the world for various therapeutic segments. Currently, we operate in over 70 countries across 6 continents. Most respected pharma company.
We have seen that HMOs are components unique to human milk, which are surprisingly very abundant, but devoid of any nutritive function, leading us to wonder what they actually do. Revealing that HMOs play a key role in supporting the immature immune system of infants, thus protecting them at a time of great vulnerability when their defense system is not yet fully functioning. HMOs also help to educate the developing immune system in order to make it fully functional. So, how do HMOs do that? HMOs help the immune defenses in 4 major ways. First, they help establish a protective commensal gut microbiota. Second, they block pathogens from doing harm. Third, they strengthen the gut barrier function. And fourth, they help educate the developing immune system. The more you learn about HMOs, the more you will understand what makes them so specific and beneficial.
Deflon 500, the world's first oral drug with international guideline recognition for hemorrhoidal disease and chronic venous disease. Deflon 500 is the ideal partner for your hemorrhoidectomy. With a dose of 2 TDS for 4 days, 2 BD for 3 days, you will get an inflammation-free and bloodless access to the site of surgery. For varicose patients with a dose of 2 tablets daily for 3 months, you can provide rapid relief from symptoms such as leg pain, night cramps, and sensation of heaviness. In type 2 diabetic patients, Dimectin MR60 achieves potent HbA1c control up to 6.5% without compromising hyposafety. Cavasil provides a stronger BP reduction compared to other RAS inhibitors.
Our people, our partners, our technology, the foundation to world-class healthcare. Emma Pharma, service for health.
Good afternoon, ladies and gentlemen. Welcome to the 8th sessions of the Gall Medical Association. Sustaining healthcare amidst challenges. This year, the sessions will be conducted under that theme. In keeping with the global pandemic situation, the academic sessions of the GMA will be conducted as a virtual conference with live broadcasting. Thank you all for joining, and please stay connected with us for a fruitful academic experience. To start the proceedings of the day, let me warmly welcome the President of the Gall Medical Association, Professor Sampath Gunawardana, Professor of Physiology, Faculty of Medicine, University of Ruhuna, to speak a few words.
Thank you. Good afternoon, ladies and gentlemen. 80th Annual Academic Sessions of GMA is about to begin. I am privileged to speak a few words before the beginning of the academic sessions. GMA is reputed to have a very rich academic sessions filled with symposia, plenary lectures, oral and poster presentations, etc. This year too, we have decided to continue the same tradition of offering a rich academic experience, even though we are challenged by an unprecedented pandemic in our lifetimes. To overcome the challenge, we have decided to go online without compromising the quality. A lot of hard work and planning was done, and here we are about to begin our virtual academic sessions. Let me welcome all of you to enjoy the academic sessions of Gall Medical Association, and please be with us in the coming 1.5 days. Thank you.
To start off the academic sessions, we have the first free paper session, which will be co-chaired by Dr. Isha Vaidyaratna, Senior Lecturer in Anatomy, Faculty of Medicine, University of Ruhuna, and Dr. Samantha Lelwala, Consultant Surgeon, Teaching Hospital, Karapitiya. I kindly invite the co-chairpersons to the head table.
Good afternoon, ladies and gentlemen. On behalf of my co-chairperson, I would like to welcome you to the first free paper session of the annual academic sessions of the Gall Medical Association. We have 6 oral presentations for this session, and there will be 8 minutes for each presentation, followed by 2 minutes of discussion. We would like to remind the audience to direct your questions through the Q&A box. We'll move on to the first presentation, and the title is COVID-19 Surveillance During the Early Stages of the Pandemic in the Southern Province, Sri Lanka, authored by Vijayaratna WMDGB, Gunasena S, Nagahawatta ADS, Veerasinghe NP, Tilakaratna LG, Nicholson B, Woods C, Dantanarayana N, Gunasekara N, Dharmasiri GNJ, Mahalyanige DT, Vikramsinghe SS, Tabru HHPMJ, Piyasiri DLB, Priyanti D, Leuke Bandar R, Ubesekara HA, Bodhinayaka CK, Devasiri IV, and Amarasena TSD. The paper will be presented by Vijayaratna WMDGB.
Good afternoon. Our study is on COVID-19 surveillance during the early stages of the pandemic in the southern province, Sri Lanka. COVID-19 RT-PCR testing facility established in the Department of Microbiology, Faculty of Medicine, University of Ruhuna, to support the National COVID-19 Diagnostic Network of the Ministry of Health since May 2020. By that time, there were few RT-PCR machines available in the country. Therefore, we took the challenge of mobilizing the existing resources to cater the national need. Surveillance testing for COVID-19 infection helps to identify emerging clusters within the country. This study aims to assess the COVID-19 status in the southern province at the initial phase in 2020. This was a prospective observational study conducted among patients attending the outpatient departments of the three main hospitals in the southern province: Teaching Hospital Karapitiya, District General Hospital Matara, and District General Hospital Hambantota. Patients' demographic data, relevant clinical information, and exposure to the disease was documented. From all patients, a nasopharyngeal and an oropharyngeal swab was collected and tested for COVID-19 using CDC RT-PCR test kit. Results. This slide shows the epic curve of the COVID-19 patients in Sri Lanka from the beginning to date. And you can see where our study period falls from 19th June to 20th November 2020. That is, it covers the latter part of the first wave and the initial part of the second wave. From the southern province, we have enrolled a total of 859 patients, out of which 44.8% were from Galle, 28.1% from Matara, and 27.1% from Hambantota districts. Of the study sample, 57% were male patients. According to the age distribution, 89.8% of them belongs to the age group of 15 to 59 years. This slide shows the distribution of the occupation. Only 290 patients responded to this question, and out of that, 12.76% were frontline workers involved in combating COVID-19. So they were doctors, nurses, other healthcare workers, and people from armed forces and police. Then we have checked the presence of fever, cough, and sore throat as features of ILI or influenza-like symptoms in the study group. From the total study group, 29.4% had at least one feature suggestive of ILI. Regarding the complaining symptoms at the time of the PCR testing, 14.5% had fever, 25.5% had cough, 7.8% had common cold, 24.3% had sore throat, 5.4% had shortness of breath, and 0.8% had diarrhea. None of the surveyed participants has been previously positive for COVID-19. 4 of them has been tested previously for COVID-19, but found to be negative. None of the surveyed participants has been previously admitted to a COVID ward or been quarantined in COVID-19 isolation camp. In the study group, there were 20 people with possible conditions leading to immunosuppression, such as diabetes, renal failure, and those who are on immunosuppression drugs. And there were 2 pregnant mothers in the study group. Then we check the potential exposure to COVID-19 in the study group. In this, 9.4% had exposed to positive patient before treatment. Another 1.4% exposed to positive patient after discharge from the hospital. 1.9% exposed to first-line contact after the period of quarantine. 7% has been exposed to foreigners or from people from overseas returning. Another 7.9% exposed to people from armed forces or police. So, as a whole, from the study group, 9.1% of people had some sort of potential exposure to COVID-19. Then we move to the test results of the COVID-19 RT-PCR. From the study group of 859 tested, only 1 became positive for COVID-19 RT-PCR test. This person was from Matara and had sore throat at the time of testing. He has been exposed to a positive patient while at work in Western Province. He is a worker from the Colombo Harbour. So if you plot our findings in the pickup, you can see our positive finding was towards the end of the study period. It is more informative if we plot the same in the data from the southern province. So this slide shows the distribution of confirmed COVID-19 cases reported from the southern province. So you can see the first cases from Galle and Mathura district were reported in March 2020, and the numbers remained low until early November. From 14th of November, there's a sudden increase of cases in the southern province. So with this increase, the community positive case found in our study. So there's a positive rate in this total study sample of 0.12%, and it is high, 0.39% among those who are having symptoms suggestive of ILI. The overall prevalence of COVID-19 in the community of the southern province of Sri Lanka is 0.04 per 100,000 population. Therefore, we'd like to conclude that the prevalence of COVID-19 in the community of southern province of Sri Lanka was low, with no evidence of infection among asymptomatic population during the latter half of the year 2020. These were our references, and we would like to acknowledge the administrative support given by Professor Sujiva Amarasena, Vice Chancellor of University of Brunei, Professor Vasantha Devisiri, the Dean Faculty of Medicine, and all officials in the Ministry of Health and staff of Department of Microbiology, Faculty of Medicine, Galle. We would like to also thank the financial contribution by the National Research Council Rapid Response Grant and the Duke University, USA. Thank you.
Thank you for your presentation. The paper is open for discussion. I would like to remind the audience to direct your questions through the Q&A box.
Please start. I think time is up. The next presentation is on notified incident cases of dengue and leptospirosis. Time series analysis for two commonest vector-borne diseases in Sri Lanka. Papers by Darshana, ILAN, Shamika, RMA, and the paper is presented by Darshana, ILAN.
I am Dr. Darshana from Department of Community Medicine, Faculty of Medicine, University of Brunei. Our study is notified incident cases of dengue and leptospirosis, time series analysis for two commonest vector-borne diseases in Sri Lanka. As you all know, dengue and leptospirosis are considered as the two commonest vector-borne diseases in Sri Lanka, which have high case fatality rate. According to Epidemiology Unit, in 2020, dengue had 0.01% case fatality rate and leptospirosis had 0.43% case fatality rate. In Sri Lanka, we have good disease surveillance system. So under that disease surveillance system, each and every patient treated for leptospirosis and dengue will be notified into Epidemiology Unit using H309 and 99 form. Apart from that, due to imports of those two disease conditions, there are a special surveillance system as well as sentinel surveillance for leptospirosis and dengue in Sri Lanka. Now I will explain why we use time series analysis approach in our study. Time series analysis is a specific way of analyzing a sequence of data points collected over an interval of time. In our study, we have used monthly notified incident cases of dengue and leptospirosis for 12 years duration. So we had series of data which have collected through a long time period. So we can use time series analysis approach in our study. By using time series analysis approach, we can ensure any trends or patterns as well as any seasonality in those two selected disease conditions. Apart from that, interestingly, we can use time series analysis approach for the forecasting of those two diseases. That means we can predict future incident cases of dengue and leptospirosis based on the historical data which already have collected. Although there are several approaches in the time series analysis, we use best as well as commonly used method of the ARIMA model in our study for the time series analysis. ARIMA means autoregressive integrated moving average. And when there is a seasonal variations, we can combine ARIMA model with the seasonal component. We call it as the ARIMA model. By forecasting incident cases of dengue and leptospirosis, we can identify the disease outbreak situations in future, as well as we can allocate resources for the curative sector and the preventive sector for the management of the patients, as well as we can plan and implement preventive programs for the dengue as well as leptospirosis. With these justifications, we decided to do a study to develop two separate models in order to forecast the monthly notified incident cases of dengue and leptospirosis in Sri Lanka. So we did the retrospective time series analysis, and we collected data through publicly available website of epidemiology unit, which were collected through routine disease surveillance system based on H399. Data were collected from 12 years duration, January 2010 to April 2021, and monthly notifiable incident cases of those two diseases were recorded. Data analysis were done using Minitab statistical software. Level of significance was considered as 0.05 for residual analysis, and ACCA information criteria was used to select the best fit models to assess model accuracy. So when we did data analysis, first we draw the time series plot to check whether the data is stationary for mean and variance. If the data are not stationary for variance, we did natural log transformation. And to do the data is stationary for mean, we did differentiation, and then we draw the parallelogram of ACF to check are there any seasonality or not. If the seasonality was identified, we did the seasonal differentiation to remove the seasonality, and then again draw the parallelogram of ACF to confirm the stationary of data. After confirming the stationary of data relevant to the variance and mean, we draw the correlograms for the PACF also, and using the correlograms for ACF and PACF, we find the simple PQ values and capital PQ values of the model. Then we did the residual analysis to identify the significant models by checking the autocorrelation, normality, and randomness. And finally, AIC was calculated for the selected significant models to assess the model accuracy, and best fit model was selected according to the lower AIC value. Now I will move on to the results. According to the result, first we try to identify are there any correlation between the reported monthly incident cases of dengue and leptospirosis. However, we got PSNR value as minus 0.04, so we consider it as almost equal to 0, and we concluded that there is no correlation between the reported monthly incident cases of dengue and leptospirosis. However, the direction of the correlation was noted as negative, so we can assume that there is a negative correlation between leptospirosis and dengue monthly incident cases. That means when the leptospirosis cases are increased, dengue cases may be decreased. Then we draw the time series plot for dengue and leptospirosis separately. As you can see in the given slide, you can see most variations in the leptospirosis compared to the dengue. However, according to these two time series plot, we identify both dengue and leptospirosis data were not stationary with respect to mean and variance, and we noted trend and seasonality in the given two data set. So now I will consider dengue and leptospirosis separately. First, I will consider the dengue. For the dengue, after seasonal differentiation, we draw correlogram for ACF and PACF. Based on these two correlograms, we identify possible values for AR and MA component of the model. Based on these suggested values for AR and MA component of both ARIMA and seasonal component, we identify 11 possible models for dengue. So then we did residual analysis for those 11 models. We did Box-Pierce test to assess the autocorrelation, Anderson-Darling test to assess the normality, and Run test to assess the randomness. By using these three tests, among 11 models, only 2 models were remained significant after residual analysis. So then we calculated AIC for those 2 remaining significant models. Among those 2 models, only ARIMA model 312 with seasonal component 011 was identified as the best fit model for dengue, which have lowest AIC. When consider the leptospirosis, these are the correlograms for ACF and PACF of leptospirosis. Using these 2 correlograms, we identify these suggested values for the AR and MA component of the both regular ARIMA component and the seasonal component. Using these suggested values, we identify these 12 models for the leptospirosis as possible models. However, after the residual analysis, only 3 models remain significant. And then we calculated AIC for those 3 significant models. And among them, ARIMA model 111 with seasonal component 011 was identified as the best fit model for the leptospirosis. Then we did the forecasting. Under the forecasting, seasonal peak in dengue incident cases can be expected in the July 2021, while leptospirosis in the November 2021. So based on these results, we can conclude that identified 2 models can be used to forecast of incident cases and impending outbreaks for dengue and leptospirosis. And these informations can be used for the management of those 2 communicable diseases, and this information will be helpful for the healthcare planners of the country for implementing preventive and curative measures for these 2 deadly diseases. These are the references we have used for our study, and thank you very much for the given opportunity to present our study findings in this forum. Thank you very much.
Thank you very much for your valuable presentation. Now the paper is open for discussion. We have only 15 seconds. There are no questions from the audience, therefore we will move to the next paper.
We'll move on to the third presentation for today. The title is Evaluation of a Staining Technique Using Toluidine Blue in Comparison to Gram Stain for Direct Detection of Bacteria in the Positive Blood Culture Broth. Authored by Kumara YNB, Vikram Singh SS and Piris HH. The paper will be presented by Vikram Singh SS.
Evaluation of a staining technique using toluidine blue in comparison to gram stain for direct detection of bacteria in the positive blood culture broth. Early administration of appropriate empirical antibiotic treatment has enhanced the survival of patients with bacteremia. Direct gram stain smear positive blood culture broth is much helpful in the rapid identification of the causative microorganism and determining the empirical antibiotic treatment. The morphology of bacteria may change due to the prior antimicrobial therapy of the patient. The species of gram-negative rods may become filamentous and pleomorphic. Also, bacteria can be easily misidentified because of the similarity of the morphology of the bacteria. No other staining technique has been used as an alternative to gram stain for direct staining of the positive blood cultures. Chisborough recommends that bacteria can be easily detectable if the preparation is stained using toluidine blue 0.5 weight volume rather than gram staining technique in a thioglycolate broth culture according to their morphology. The aim of the study was to evaluate the staining technique using toluidine blue in comparison to gram stain for the direct detection of bacteria in positive blood culture broth. Objective was to evaluate the accuracy of a staining technique using toluidine blue in comparison to gram stain for the direct detection of bacteria according to their morphology in the positive blood culture broth by comparing the sensitivity, specificity, positive and negative predictive values of toluidine blue stain with the gram stain. This was a diagnostic cross-sectional study using 155 positive blood culture broths collected from microbiology laboratory in Teaching Hospital, Karapitiya. Direct smears of positive blood culture broths were stained with gram stain and toluidine blue stain. Culture isolates of these blood samples were stained with gram stain and considered as the gold standard. Ethical approval was obtained from the Ethics Review Committee of Faculty of Allied Health Sciences, University of Ruhuna. Sensitivity, specificity, positive predictive value and negative predictive value were calculated using direct smear results of gram stain and toluidine blue stain in comparison to gram stain results of the culture isolates, which was considered as the gold standard. Sensitivity was the proportion of positive test results out of all culture correct results, and specificity, the proportion of negative test results out of all culture incorrect results, and the positive predictive value, the probability that subjects with a positive test truly have the disease, and negative predictive value, the probability that subjects with a negative test truly do not have the disease. The validity of the test was assessed with 95% confidence interval. In results, out of 155 isolates, 67.1, 18.7, 6.5%, and 7.57 organisms identified as cocci, bacilli, coccobacilli, and yeast respectively. The image shows microscopic appearance of the direct smears stained with toluidine blue. This table shows sensitivity, specificity, positive predictive value, and negative predictive value with 95% confidence interval of gram stain and toluidine blue compared to the gold standard culture results. In the identification of cocci, sensitivity, specificity, positive predictive value, and negative predictive value of gram stain and the toluidine blue stains were close to 100%. When detecting bacilli, sensitivity of both gram stain and toluidine blue stain was low, but positive predictive value is higher in toluidine blue stain. Specificity of both stains were high, indicating the low false positive rate. The sensitivity, specificity, positive predictive value, and negative predictive value were higher in toluidine blue stain than gram stain for the identification of coccobacilli. Yeast were precisely identified by both gram stain and the toluidine blue stain. Overall, microorganisms in direct smears stained with toluidine blue were more clearly visible as the background staining was minimal. This microscopic image shows gram stain and toluidine blue staining of direct blood culture broth. In conclusion, significant differences were not observed when identifying cocci and bacilli from direct smear of positive blood culture using both gram stain and the toluidine blue stain. However, there was a significant difference between the two stains in the identification of coccobacilli. all yeast could be identified with same effectiveness. Toluidine stain is useful for identifying bacteria and yeast according to their morphology in positive blood culture broths as an accurate, rapid, and cost-effective technique. However, in routine practice, identification of the microorganisms as either gram-positive or negative is very important. Staining with toluidine blue helps in the identification of different morphologies only. Thank you.
Thank you very much for your presentation. There was one question. I would like to remind all the audience to direct your questions through the Q&A section. And the question is, what are the disadvantages of toluidine blue stain?
Thank you, Madam, for your question. And regarding toluidine blue, as it is a simple stain, we won't be able to differentiate whether it is a gram positive or gram negative. That means we can't it doesn't give any differential stain to the organisms. But compared to that gram stain, being a differential stain, we can identify the organisms as gram positives and gram negatives. That's the one disadvantage of the toluidine blue, because it only gives the morphological identification of the organism.
Thank you.
I have a question to ask. Is it okay? Is it okay to ask a question?
Yes.
Yes. The gram stain and this stain, what is it expensive or is it time consuming? In those aspects, can you compare these two?
Gram stain actually takes around 3 to 4 minutes to stain, and it's a little bit expensive than the toluidine blue stain. Compared to that, toluidine blue stain just take only 2 minutes to stain a smear, and also it's less expensive than the gram stain, because gram stain we have to use 3 or 4 staining reagents, whereas in the toluidine blue we have to use 2 staining reagents. Therefore, comparing all these things, less expensive method is the gram toluidine blue, and also it takes less time than the gram stain technique.
Thank you.
There's some more time for the questions. All right, thank you very much for your presentation. We'll move on to the next presentation. That's on prevalence of pain among institutionalized older adults in Galle district, a descriptive study by Abesekara, NWBY, and De Souza, GED. And the paper will be presented by Abesekara, NWBY.
Good evening to all of you. I'm Buddhini Abesekara from Faculty of Allied Health Sciences, and I'm going to present the findings of our research under the topic of prevalence of pain among institutionalized older adults in Galle district, a descriptive study. When we talk about the population aging, it is a significant social problem worldwide, and Sri Lanka's second line as it is. Few decades back, Sri Lankan family structure was enough to take care of their own elders. But due to the gradual changes of society and family structure compelled many elders to appeal for elderly care facilities in institutions at present. So, the number of elders who seek institutionalized care increases day by day, and they face so many problems other than to live away with their loved ones. Those problems can be financial, physiological, and psychological. Among those issues, suffering from any kind of pain due to the physical or psychological reasons take a huge part in their lives. Though these problems are common and negatively impact the quality of lives of the affected elderly, they are most neglected conditions because people consider them as the issues which emerge with the elderly life. When we talk about the pain, it is a common condition with an unpleasant sense of discomfort that persists or progress over a long period of time. And that can be due to the physiological or psychological reasons. After some time, that can become a catastrophizing belief that related to the pain. Pain catastrophizing refers to a set of exaggerated and dominating negative cognitions and emotions during actual or perceived painful stimulation. With this background, the study was designed to assess the prevalence of pain in institutionalized older adults in the Gold District. Ethical approval for the study was obtained from the Ethics Review Committee of the Faculty of Allied Health Sciences. A distributed cross-sectional study was conducted in 20 elderly homes in Gold District, and 310 elders were enrolled in the study with their informed consents. We have used an interviewer-administered questionnaire and validated single version of pain catastrophizing scale to collect data and to assess the physical and psychological pain. Data were analyzed using SPSS version 25 for Windows, and p-value was considered as less than 0.05. Pain catastrophizing scale was a tool that is used to assess the catastrophizing pain, and it is considered as an instrument which is used to quantify the catastrophizing thinking related to pain. According to the scale, one has to indicate the degree of which they experienced each of 13 thoughts or feelings when experiencing pain. Total score of pain catastrophizing scale range from 0 to 52, and more than 20 indicates a considerable catastrophizing pain. Subscales of pain catastrophizing scale consist of rumination, magnification, and helplessness. Let's move on to the result session. As you can see here, this sample was consist with 310 elders with the mean age of 74.58 years, and about 65% of them were females. When we consider the socio-demographic characteristics of this study sample, majority of them were unmarried and 75.5% of them had a 1 to 5 year duration of institutionalized life. We have used the Mannequin of Manchester definition of chronic widespread pain to assess the physical pain. As you can see in this figure, most of the elders had limb pains other than to bed pain, and 60.6% of them had pain in more than one side, and 52.3% of them got treatment for their pain. According to the results of the assessment of pain in the study sample, 78.7% of them had any kind of pain. As you can see in this chart, most of them were unable to point out the exact reason for their pain, and they were suffering from chronic psychological pain than physical pain. As you can see, according to the findings of the study, 91.9% of subjects had catastrophizing pain, and 29% of them had considerable catastrophizing pain according to the pain catastrophizing scale. According to the subscales of pain catastrophizing scale, from the total subject who had catastrophizing pain, 77.7% had helplessness, 82.9% had magnification, and 83.9% had rumination. So, according to the findings of this study, we can conclude that prevalence of both physical and psychological pain is high among institutionalized older adults in the study sample. And it is very important to take measures to detect their problems early and to plan appropriate interventions to improve the quality of lives of these affected institutionalized older adults. These are some of the references that I have used for my study. Thank you all for listening to me and giving me this valuable opportunity.
Thank you very much for your valuable presentation. And now the Paper is open for the discussion. Please send your questions through the Q&A box.
Congratulations on your study. You have mentioned that you measured chronic pain. I didn't see a definition saying what is the duration of this pain that you have considered to say that it's chronic.
Thank you, madam, for your question. Sorry for not mentioning that in my slides, but we have considered the chronic state as anyone has pain more than 3 months. That it is the statement that we have used for chronic pain.
Okay.
Thank you, madam.
Any further questions, please?
There's another question. Is your finding significantly different from published data?
No, yes, madam. Yes,
Did you hear the question?
Yes, madam. The data is quite different from the previous studies. Yes, so there was a significant difference with the findings of our study and the previous studies.
The findings of your study is different from the others?
Yes, madam.
From the published data?
Yes.
Any possible reason?
Madam, there were a less number of studies carried out among the institutionalized elders previously. We have found some studies which were conducted in Colombo district with institutionalized elders. When comparing with those findings, there are some sort of difference with the percentages of these findings in this study, but I don't know the exact reason for that. I think institutionalized elders may suffer from pain because they are unable to express that because they are not with their loved ones, and they are always trying to compensate that with their current situation, and they try to adjust with their lifestyles and ignore them. So I think because of the lack of attention, they are more prone to neglect their problems. So I think that is the reason for their significant difference in these findings.
Yeah, thank you very much. We'll move on to next paper.
We'll move on to the next presentation. The title of the presentation is Incidence of Anthracycline-Induced Cardiotoxicity in Breast Cancer Patients Admitted to Teaching Hospital, Karapitiya, authored by Sandamali J.N., Hevavasam R.P., Fernando M.A.C.S.S., Jayatilaka K.A.P.W., Madhurave R.D., Sadanandan P.P., Ekanayaka U., and Horadugoda J. The paper will be presented by Sandamali J.A.N.
Good afternoon, dear sir and madam. Topic of my study is incidence of anthracycline-induced cardiotoxicity in breast cancer patients admitted to the teaching hospital, Karapitiya. Anthracyclines are commonly used to treat wide variety of solid organ tumors and hematologic malignancies. They are among the most effective anti-cancer drugs ever developed, and introduction of them increased the survival rate from 30% to 70%. However, dose-dependent cardiotoxicity of anthracyclines compromises its clinical effectiveness. Cardiotoxicity induced in anthracycline chemotherapy can be divided as acute, subacute, and chronic cardiotoxicity. Although echocardiography is a commonly used method to identify cardiotoxicity, sometimes it is not a suitable method as it detects the abnormality after having some degree of damage to the myocardium. Therefore, selective biomarkers such as troponin and N-terminal probrain natriuretic peptide have been identified as very useful biomarkers to identify subtle changes in the heart. When considered the incidence of anthracycline-induced cardiotoxicity in Sri Lanka, studies have never been carried out. Therefore, objective of this study was to determine the incidence of anthracycline-induced acute and early onset chronic progressive cardiotoxicity in cancer patients admitted to the teaching hospital Karapitiya. This is the methodology. Ethical approval was obtained from the Faculty of Medicine, University of Ruhuna. A prospective cohort study was performed at Teaching Hospital Karapitiya. All newly diagnosed breast cancer patients who were administered with anthracycline and cyclophosphamide for the first time and who gave informed consent were enrolled in the study. These exclusion criteria were considered when recruiting the patients. An interviewer-administered questionnaire was used to collect the socio-demographic data and other relevant information. Any other information required was collected from the BHT and investigation reports. 196 patients were recruited to the study. Blood was collected from each patient at 4 occasions, 1 day prior to anthracycline chemotherapy, 1 day after the first dose of chemotherapy, 1 day after the last dose, and 6 months after the completion of anthracycline chemotherapy. The concentration of cardiac troponin I and the NT-proBNP were estimated. The reference value for the NT-proBNP was considered as less than 125 picogram per ml, and the positive cardiac troponin I concentration was considered as more than 0.01 nanogram per ml. However, a significant elevation was considered as more than 0.04 nanogram per ml. This is because this is the value which evidences myocardial necrosis. These are the results. When considered the baseline characteristics of patients, the mean age of the patients recruited to the study was around 53 years old, and the cumulative dose of anthracycline received was around 340 milligram per square meter. More than 51% of patients had Nottingham grade 2 cancers, and more than 80% of patients received doxorubicin as the anthracycline drug. And more than 98% of patients received 4 cycles. More than 42% of patients had diabetes mellitus, and more than 35% of patients had dyslipidemia. When compared the biochemical parameters among 4 stages, a significant difference was observed between baseline value and the 1 day after the first dose of anthracycline chemotherapy, 1 day after the last dose, and 6 months after the completion of anthracycline chemotherapy. However, none of the patients showed these biochemical parameters beyond the reference value 1 day after the first dose of anthracycline chemotherapy. There were more than 31% of patients with NT-proBNP concentration more than the reference value 1 day after the last dose, and more than 46% of patients 6 months after the completion of anthracycline chemotherapy. There were more than 10% of patients with cardiac troponin I concentration more than 0.04 nanogram per ml 1 day after last dose, and
more than 41% of patients 6 months after the completion of anthracycline chemotherapy. Logistic regression analysis was performed to identify the risk factors which affect for the occurrence of cardiotoxicity. According to the univariate and multivariate analysis, cumulative dose of anthracycline more than 350 mg per square meter was identified as the mostly affected risk factor for the occurrence of cardiotoxicity. These biochemical parameters used in this study because troponins are highly sensitive and specific cardiac biomarkers released to the circulation when there is a myocardial injury. Also, NT-proBNP is identified as a reliable marker to investigate anthracycline-induced cardiotoxicity as it correlates with left ventricular dysfunction. According to the results, cardiotoxic evidences were observed 1 day after the last dose and 6 months after the completion of anthracycline chemotherapy. However, influence of cyclophosphamide for the development of subclinical cardiotoxicity cannot be excluded as anthracycline was given only as a combination therapy. Risk factors, including radiation therapy and other cardiotoxic drugs, may also contribute for the development of subclinical cardiotoxicity, as this study was conducted as a prospective cohort study. According to this study, although acute cardiotoxicity was not observed in these patients, incidence of early onset chronic progressive cardiotoxicity was significantly high. Therefore, it is recommended to carry out long-term follow-up to detect the cardiotoxicity in the patients receiving anthracycline chemotherapy. These are the sum of the references. Thank you.
Thank you for your presentation, and the paper is now open for discussion.
Yeah, there's one question from Sudhira Jaisingh. Did you compare the effect of two drugs, which is more cardiotoxic?
Yes, actually, I compared two drugs, but there was a problem with the number of cases because the more than 80% of patients were given doxorubicin and only 20% was given epirubicin. Anyway, with the literature, the doxorubicin is the most cardiotoxic drug. In this study, we couldn't get significant results because of this less number of cases in epirubicin.
I'd like to ask two questions. Congratulations on your presentation.
Thank you.
Why do you say that this is a cohort study?
Cohort study.
Were there any, to my understanding, without a comparative arm, you cannot say that it's a cohort study. And were there any missing dropouts in the study?
Yes, madam, there were dropouts, but actually I want to get 196 participants to get significant results. Therefore, when there are dropouts, I again collect data from new patients and try to finish the study with 196.
Okay, thank you.
Thank you, madam.
All right, thank you. This is the last presentation. Cardiac rhythm abnormalities among patients underwent total cavopulmonary connection completion, authored by Surya Sena, IAGP, Frammer A, Jones B. Paper will be presented by Surya Sena, IAGP.
Good morning. I'm Dr. J.G.P. Suryasen. I'm the Acting Pediatric Cardiologist Teaching Hospital, Rathpura, and I'm going to present one of my research works done during my foreign training at the Royal Children's Hospital, Melbourne. So this is about cardiac rhythm abnormalities among patients undergoing total cardiopulmonary connection completion, or commonly referred as Fontan completion. The general objective was to describe the cardiac rhythm abnormalities and outcome in patients with physiologic ventricular hearts undergoing TCPC completion. And the specific objectives were to determine the incidence of the occurrence of arrhythmia following TCPC, to describe the outcome of arrhythmia following TCPC, to identify pre-surgery associated factors with the occurrence of arrhythmia following surgery. So this is the methodology. Ethics approval is obtained from the Royal Children's Hospital, Melbourne, Human Research Ethics Committee, and also the governance authorization was obtained from the Melbourne Children's Campus. This was a retrospective longitudinal study done on patients who underwent Fontan completion at the Royal Children's Hospital from January 2015 to September 2020, and patients were recruited by consecutive sampling, and the data was obtained from hospital records, mainly from the cardiology unit database, cardiac catheterization database, and the missing information was obtained from patient records. Statistical analysis was performed using SPSS version 25. All demographic, morphologic, operative, and post-operative variables summarized with descriptive statistics. Independent sample t-test used to identify factors associated with arrhythmia. Significance levels was considered as 5%. So there were 102 patients who underwent surgery during this study period, and out of this, 64% were male and 36% were female. And this table illustrates the underlying prominent ventricle. So 53 patients had the left ventricle as the prominent ventricle, and 47 patients had the right ventricle as the prominent ventricle, and 2 had undetermined prominent ventricle. And all patients has had an extracardiac type of Fontan completion in this cohort, and majority or 93% of the patients has had a fenestrated conduit as the conduit during the surgery. So this table illustrates the underlying main diagnosis. So we can see hypoplastic left heart syndrome was the commonest underlying diagnosis, followed by tricuspid atresia, unbalanced AVST, pulmonary atresia with intact ventricular septum. So this is the age distribution. We understand that majority of the patient cohort is within 2 to 6 years age group. So out of these 102 patients, 25 patients developed arrhythmia following surgery. So the incidence of arrhythmia was 24.5%. So out of these 25 patients, 13 had tachyarrhythmia, whereas bradyarrhythmia was less common, and supraventricular tachycardia was the commonest type of tachyarrhythmia, and the bradyarrhythmias was characterized by AV block, junctional bradycardias, and nodal bradycardias. And out of these 25 patients, 15 patients has developed the arrhythmia during their initial cardiac ICU stay, and 3 patients has developed arrhythmia during the cardiac ward stay, and 4 patients developed arrhythmia after discharge from hospital. And this is the time of arrhythmia occurrence. We see more than half of the patients has developed arrhythmia on the day 1 following surgery. And this chart illustrates the predictability of preoperative factors on occurrence of arrhythmia. So here, none of these variables, gender, predominant ventricle, or main diagnosis, is predictable of occurrence of arrhythmia following surgery. And here, the pulmonary artery pressure or the atrial pressure, both of which were measured during the pre-procedure cardiac catheterization, was not predictive of occurrence of arrhythmia. However, interestingly, the cardiac bypass duration and the aortic cross-clamp duration was significantly predictive of occurrence of arrhythmia following surgery. So, the mean follow-up duration for the patient cohort was 28.6 weeks. And out of this, 71% of the patients were free from arrhythmia at the last clinic visit. 5 patients has required permanent pacing, and 5 patients has ended up with Fontan failure, and there have been 3 mortalities. So this table illustrates the association between occurrence of arrhythmia and death. So those who had arrhythmia, the mortality rate was 7.7%, whereas it was 1.4% in those who didn't have a arrhythmia. So arrhythmia has a significant association with occurrence of death. So the conclusion is longer cardiopulmonary bypass duration and cross-clamp durations predict high arrhythmia burden following TCPC completion. Postoperative arrhythmias are associated with high post-procedure mortality. Thank you. These are my references.
Okay, thank you. And now the paper is open for discussion. Please direct your questions through Q&A box.
May I ask the question? Thank you for your presentation. Just would like to know what's the dropout rate?
So this was a retrospective study. So we have enrolled all the consecutive patients. There were 102 patients who underwent Fontan surgery from 2015 to 2020. And so when we recruited each and every patient during the study period.
Any further questions? Then thank you very much. And I would like to thank all the authors and presenters and the audience as well. And this will conclude our first session of this meeting. Thank you.
Thank you, co-chairpersons. Next in line, we have the first plenary lecture. I cordially invite the co-chairs for the session, Professor Channa Yathugoda, Professor in Parasitology, Faculty of Medicine, University of Roorkee, and Dr. Arosha Vikrama, Consultant Physician, Teaching Hospital, Karapidiya, to the head table.
Good afternoon, everybody. Welcome to the plenary lecture on snakebite envenoming a treatment, future perspectives, by Professor Aryarani Jnanadasan, Senior Professor in Medicine, Faculty of Medicine, University of Colombo.
Good afternoon. Let me first of all thank the organizers of the Gall Medical Association for giving me to deliver this plenary lecture on snakebite envenoming treatment, future perspectives. Snakebite is a neglected public health problem causing enormous suffering and disability. WHO has estimated about 80 to 140,000 of people die each year from snakebite, and 400,000 of people are really left with permanent disability as a result of snakebite envenoming. WHO has also re-recognized and included snakebite envenoming to its list of Category A neglected tropical diseases in 2017. The Working Committee of the WHO has launched a roadmap in order to reduce the incidence of snakebite by 50% before the universal health coverage in 2030. The WHO also has recommended snakebite to be a notifiable disease of every country. This slide has shown the geographical distribution of snakebite envenoming and deaths in every country globally. This is the roadmap which has 4 pillars. They were the major objective of this roadmap, which has safe and effective treatment, empowering and engaging communities, stronger health systems, and partnership and coordination and resources. And in order to reduce the snakebite by 2030. And today for the lecture, we will be concentrating on safe and effective treatment. Snake venom, it is a cocktail of many toxins. They have non-enzymatic, enzymatic proteins, peptides with broad pharmacological properties. This multifunctional cocktail consists of phospholipases, A2, snake venom metalloproteases, serine proteases, and 3-finger toxin. These are the 4 main enzymes which causes the acute envenoming syndromes, such as local tissue necrosis, venom-induced consumption coagulopathy, neuromuscular paralysis, acute kidney injury, etc. This diagram again depicts how the venom toxin affects the different parts of the body. It affects the blood coagulation pathway and it causes consumption coagulopathy. It acts on the venom, acts on the acute kidney, acts on the kidney and causes acute kidney failure. They act at the bite site and causes local tissue damage, and which leads to necrosis. And they also act on the neuromuscular junction and it causes paralysis. In the muscles, they affect the muscles and cause rhabdomyolysis, and which in turn can also contribute to the acute kidney injury. Antivenom, what is antivenom? It is from its development in late 19th century, the only specific, effective and accepted therapeutic treatment for snakebite envenoming currently available is the antivenom, which is really single-handedly saved the lives of those who are suffering from snakebite over a century. It is also considered the gold standard treatment for snakebite envenoming globally. And this antivenom has been included in the WHO list of essential medicine in 2007. And this slide shows the Nobel Prize winner, Albert Calmette, who has manufactured this antivenom, this novel antivenom in 1895. And the first antivenom was manufactured against the Indian cobra venom. And since then, the antivenom is being used, and it's a life-saving drug. And this diagram shows the history timeline of antivenom from its inception till up to now. It has gone through lot of immunological purification, and it is being purified well up to now. So the antivenom is a polyclonal heterologous immunoglobulin. And it can be, there are two types of antivenom. You can manufacture the antivenom of different snake species, get the venom and inject and get antivenom, that is polyspecific antivenom or polyvalent antivenom. Or you can make the antivenom by getting the venom from one particular species of snake and inject it to the large animals and get the antivenom. Then it is called monospecific antivenom. The antivenom is mainly IgG molecules, and they also have the antibody fragments. The antibody IgG, if you digest the antibody with papain enzyme, then it will result in 2 FAB fragments. Those are smaller molecular weights, which really 5 kilodalton. And if you digest that with pepsin enzyme, then it will result in FAB primed component, and that is a little bigger than the FAB fragment. What is the Sri Lankan scenario with regard to snake antivenom? Sri Lanka does not manufacture our own antivenom, and we import from India, and the Indian polyvalent snake antivenom, from the beginning, at the inception, we used to get down from Hafkin Institute or Serum Institute of India. But for the last 3-4 decades, we are getting down from Bharat Serum or BIMS bioproduct, because the Hafkin Institute is no more exporting the antivenom to the foreign countries. And this particular antivenom is a polyspecific or polyvalent antivenom. It is manufactured against Indian rhesus viper, common crate, cobra, and saw-scale viper venom. And it is a lyophilized polyspecific FAB primed fragment. And as you know, in Sri Lanka, not only these 4 snakes, we also have hump-nosed viper, which is a common problem which causes morbidity and mortality, and it causes chronic kidney disease as well. So these that venom and the Sri Lankan crate venom and sea snakes venoms are not included in this polyvalent antivenom. This antivenom has been really a group of researchers from the University of Oxford and University of Colombo have done a research in Anuradhapura General Hospital way back in 1985, and they found this antivenom what we are using, the Indian antivenom, is not really effective against rhesus viper bite in Sri Lanka. So in order to bring a new antivenom, the Ox-Colombo snakebite research group worked on it, and they have manufactured a new monospecific ovine FAB fragment antivenom that is really made out of or manufactured from sheep by injecting our own Sri Lankan rhesus viper venom, and they developed this monospecific ovine and FAB fragment in contrast to FAB primed fragment, which is there in the Indian antivenom. And the preliminary dose finding study as well as the open label randomized comparison trial were conducted successfully, but unfortunately they have not reached the commercial use yet. 3 decades later, a new antivenom was manufactured by a group of researchers mainly from the Peradeniya University and Costa Rica, University of Costa Rica. Together, in collaboration, they have produced a new antivenom, indigenous antivenom, by sending the snake venoms from rhesus viper, saw-scale viper, hump-nosed viper, and naja or cobra venom was sent across to Costa Rica. And from there, the equine, from the horses, they have manufactured an antivenom, which is really a whole IgG freeze-dried polyspecific antivenom. And this antivenom has undergone preclinical studies, and was very promising in neutralizing the venom components, and now it is being tested in clinical trials in Peradeniya and other few hospitals, and the clinical trials are being carried out, but still the results are not released, but we hear that it is going to be a promising results. Then again, recently, there's another new polyvalent country-specific snake antivenom, Sri Lankan antivenom serum is on pipeline. And that antivenom also is a polyspecific antivenom or polyvalent antivenom, which is manufactured also for hump-nose viper venom. And it is with collaboration again with the University of Colombo and Serum Institute of India. And this antivenom is now ready and awaiting for the approval from NMRA, and then subsequently it will undergo clinical trials. What are the challenges and limitations of this current existing antivenom? As you know, antivenoms are the heterologous polyclonal immunoglobulin. That is really a complex mixture, complex compound, which is costly to be produced, and it has come with a range of drawbacks. What are the drawbacks? The effectiveness, safety, and availability. It has a poor effectiveness against venom-induced local effects or local necrosis and presynaptic neurotoxicity. Poor effectiveness was due to a significant geographical variation in the composition of venom, inter- and intra-species venom variability. And this process, this manufacturing process is a very complex one. It depends on two biological systems, that is snakes as well as immunized animals. And it is a very expensive product, and there is high batch-to-batch variation. It contains immunological proteins, and there are 70% of the antibodies in this antivenom are really not irrelevant medically. So they activate the immune system of the patients, and they cause adverse reactions. This slide shows the early adverse reactions, or early adverse reactions are mainly due to some are due to IgE-mediated anaphylactic reaction, some are non-IgE-mediated anaphylactic reaction. The other one is really due to mainly the pyrogenic reaction, which also very immediately within 1 to 2 hours, and the patients get, that is mainly due to the 70% of the antibodies which are not relevant, non-neutralizing antibodies in this antivenom. And after 10 days, 7 to 14 days duration, the patients who have got antivenom can develop hypersensitivity type 3 reaction, serum sickness, and they present with arthralgia, arthritis, glomerulonephritis, and vasculitis. Then this roadmap, the strategic objectives, as I mentioned, as you saw earlier, the key pillars are, there are 4 key pillars. Today, what we are going to use to talk about is safe and effective treatment. And in that, the key activities are making safe and effective antivenom, which should be available, accessible, and affordable to all. And better control and regulation of antivenom, and pre-qualification of antivenom, and investing in innovative research on new therapeutics in order to reduce the morbidity and mortality of snakebite envenoming. WHO working group has already attended to the guidelines, and they have produced a WHO guidelines for the production, control, and regulation. It was done in 2010, and it was updated again in 2017 about how to produce, how to control, how to regulate these snake venom antivenom immunoglobulins. So what are the recent advances? There is advances in biotechnology, and because of that, and the researchers have really understood about the composition of the venom because of proteomics, and proteomic and transcriptomic approaches have led for the researchers to understand this complex venom, the venom composition. So because of that, nowadays with these biotechnology and pharmacological approaches, They have led to monoclonal antibody production. Oligoclonal antibodies can be produced against various toxin components, and which can really, they have really produced human monoclonal antibodies and antibody fragments, and also recombinant antivenom for snake venom envenoming. And there are also small molecule therapeutics, which are really repurposed molecules, which can be really an adjuvant therapy or adjunct therapy for snake bite envenoming. Let us see the recent development because of the scientific development and biotechnology and recombinant technology has discovered monoclonal antibodies and oligoclonal antibodies, which has paved the way to develop novel types of antivenom based on recombinantly expressed antibodies and antibody fragments, and which has resulted a scope for recombinant antivenom. And this has an advantage to have better efficacy, less batch-to-batch variation, and less immunogenicity. So in future, we can produce it for a lower cost as well. And researchers also have discovered in African cobras, there are various types of cobras. They have found fully human antibody fragments that could cross-neutralize the three-finger toxins, which causes cytotoxicity. So it is possible that monoclonal antibodies and their fragments could be used to fortify the existing plasma-derived antivenom to improve its efficacy with low immunogenicity. What are these small molecule therapeutics or small molecule drugs? These small molecule therapeutics or small molecule inhibitors are really, they are the inhibitors of venom enzyme toxins. And as you know, these are the, we just earlier discussed about these important venom toxin, metalloproteinases, phospholipase A2, serine proteases. This is really, these small molecule therapeutics are these enzyme inhibitors. So these particular small molecular therapeutics are really based on toxin-centric approach. And this is this table shows the families which causes the snakes, which causes neurotoxicity, hematotoxicity, myotoxicity, and cytotoxicity mainly. And the venoms, the toxins are snake plasma phospholipase A2, snake venom metalloproteinases, serine proteinases, and three-finger toxins. So you see phospholipase A2 is found, mostly it is abundant in all the ranges of snakes, and the metalloproteinases in 3, so like that. So these inhibitors are really for these venom enzyme toxins. So the most of the small molecular therapeutics, I will call it as in future SMTs, are used in pharmaceutical preparations, and they are derived from natural bioactive compounds, mainly alkalis or synthetic molecules intended to act on specific targets. So many snake venom has these common toxic components, as you saw in the table also, these enzymes, which are abundant and prevalent across different snake species over the globe. So these molecules can be given orally, intravenously as an adjuvant to antivenom, also to increase the breadth of treatment efficacy. It can be used to increase the breadth of efficacy as an adjuvant. So small molecule therapeutics are potentially useful tool as an adjunct to antibody-based antivenom in future. So to produce these drugs, production of drugs are very costly. So we could use, the researchers have thought about, and they have found this, they have decided to repurpose or repositioning approach, use this approach as a powerful way to reduce the cost of these drug production, particularly for neglected tropical diseases, the disease like snake bite, which is really a poor man's disease, by reviving and expanding the indications of existing drugs to develop potential therapy for snake bite envenoming. Several such drug candidates are existing, and they have reached the clinical development, clinical trials, and they have come as indication for various other diseases like cancer treatment, oncology, metalloproteinases. And in acute infections and acute coronary syndrome, the PLA2 inhibitors have been used. So the foremost SMT is the varicipladib, and it is also the orally available prodrug is methyl varicipladib, and which are really repurposed drugs for treating acute coronary syndrome. Previously, they have gone through the clinical trials up to phase 3, and they have shown potent inhibition of the secreted phospholipase A2, which is found in the range of snake venoms. And these SMTs have demonstrated to protect against neurotoxicity, myotoxicity, and coagulopathic venom effects in variety of in vitro mice models and in vivo models, and thus they are really promising lead candidates for assessment in forthcoming clinical trials by WHO. The second most abundant enzymatic groups are the snake venom metalloproteinases, for which the matrix metalloproteinase inhibitors, namely the drug is bacimestet, is originally developed for cancer therapy, and it is orally available as a prodrug, marimestet, and it has shown to be effective in inhibiting the hemorrhagic and necrotic effects of the snake venom enzymes. So both these drugs are really promising candidates for repurposing as snake bite treatment, because the matrix metalloproteases as well as snake venom metalloproteases both share the similar structure. So because of that, both these drugs, they are also, the researchers have done research and they have found these are potently inhibit the venom, snake venom metalloprotease activities in vitro, and shown to protect against hemorrhage and dermonecrosis and lethality caused by certain snake venom in animal model of envenoming. So, however, whatever the research has shown, the clinical trials are urgently needed to evaluate the safety, efficacy, optimum mode of administration, and duration of therapy for these two drugs, that is marimestet and varicipladib, among snake bite envenoming patients. There are another two more drugs which are being used for heavy metal poisoning. As you know, dimercaprol and 2,3-dimercapto-1-propane sulfate, that is abbreviated as DMPS, have also shown to inhibit the activity of venom metalloproteases through chelation of zinc, which these enzymatic toxins rely upon. And both these drugs were also found to protect mice from the lethal effects of certain saw-scale viper venoms in a delayed drug treatment model designed to better mimic a snake bite scenario and protected against venom-induced local hemorrhage. So these DMPs or DMPS also can be used, can provide really some protection against systemic envenoming when it administers to mice orally after venom challenge. So these are really, the results are really promising, but clinical trials have to be done to establish the safety and effectivity of the small molecule therapeutics based therapies. So if the trials shows efficacy and safety, these SMT, small molecule inhibitors or therapeutics, could be used as an oral adjunct snake bite treatment in out of hospital setting as soon as the bite occurs. And it can be for, then the patient can, after the patient come to the hospital, it can be followed by a later treatment in the hospital, even in a different treatment modality. Maybe you can give it intravenously also. These drugs are available if required. So these drugs can be used pre-hospital, out of hospital setting, as well as hospital setting as well. So this diagram really depicts these drugs are really repurposed drugs. They have been already discovered and they have preclinical studies have really showing the marimestet, bacimestet, and varicipladib and both together also they are effective in preclinical studies in vitro, and now we have to do the clinical trials, and if they show safety and efficacy, then the regulatory approvals can be in future, it is really can be obtained, and in future they can be used as an adjuvant drug in the case of snakebite envenoming. So in conclusion, conventional antivenom-based polyclonal antibodies derived from animals still remain the mainstay of the therapy, along with supportive medical and surgical care in spite of their drawbacks, and they have saved countless lives of snakebite envenoming. Nevertheless, major scientific and technological advances are facilitating the development of a new generation of antivenom comprising human monoclonal, oligoclonal antibodies with antibody fragments with broader and more potent neutralization capacity, as well as less immunogenicity when you compare with the conventional antivenom. And repurposed pharmaceuticals based on small molecule inhibitors used alone or in combination against enzymatic toxins such as snake venom metalloproteases, phospholipase A2 have shown promising results in animal studies. These are orally also available, orally bioavailable molecules could serve as they are available, and they could be used as early intervention in the out-of-hospital setting if confirmed to be safe and effective in clinical studies. So anyway, finally, although the conventional polyclonal antivenom is the one which is continue to save the life of countless snakebite victims every year globally, it is apparent that improved treatment modalities are highly needed, urgently needed to more effectively tackle this neglected tropical disease. Let's hope that these therapeutics will contribute dramatically to reduce the burden of death and disability on the world's neglected snakebite victims. Thank you very much for your patience hearing.
I am thankful to Professor Arinari Dasan for an excellent lecture, and to the audience for your patience. Thank you very much.
Thank you, co-chairpersons. Next, we will go for a short break, and the sessions will recommence at 3:50 p.m. Thank you.
This is Sophie. She just turned 45. A wife, a mother, a daughter, a friend, a teacher. She is many things to many people. She was 17 when she first met her partner. 28 years and 3 children later, they still look at each other the same way as the day they met. Every summer, they go to the countryside cottage of Sophie's parents in a hope of a quiet escape from their busy city lives. And maybe it would be if it weren't for all the cousins and siblings and their families, of course, all trying to escape the city buzz. Many of Sophie's friends, even from high school and university days, have been visiting for years. It is probably her unconditional love for people and passion for art that brings people together. She always says, "I am lucky because my passion is what I do." Over 20 years as an art teacher, she has inspired and touched the lives of many. It's only recently Sophie has been feeling like something isn't quite right. Today, Sophie was diagnosed with breast cancer. Breast cancer doesn't only affect those who are diagnosed with it. It has an impact on families, communities, and our society. Every 20 seconds, someone is told they have breast cancer. So Sophie may be just like someone you know. One diagnosis, hundreds of lives impacted. Treating breast cancer early may provide the best chance of cure. That is why we are committed to bringing every single patient with breast cancer closer to cure. And it is this commitment that drives us every single day.
Torrent Pharma, one of India's leading integrated pharma companies. Torrent Research Center works zealously in the quest to discover better therapeutic solutions, have to their credit novel drugs that have been developed for the first time in the world for various therapeutic segments. Currently, we operate in over 70 countries across 6 continents. Most respected pharma company.
We have seen that HMOs are components unique to human milk, which are surprisingly very abundant, but devoid of any nutritive function, leading us to wonder what they actually do. Revealing that HMOs play a key role in supporting the immature immune system of infants, thus protecting them at a time of great vulnerability when their defense system is not yet fully functioning. HMOs also help to educate the developing immune system in order to make it fully functional. So, how do HMOs do that? HMOs help the immune defenses in 4 major ways. First, they help establish a protective commensal gut microbiota. Second, they block pathogens from doing harm. Third, they strengthen the gut barrier function. And fourth, they help educate the developing immune system. The more you learn about HMOs, the more you will understand what makes them so specific and beneficial.
Deflon 500, the world's first oral drug with international guideline recognition for hemorrhoidal disease and chronic venous disease. Deflon 500 is the ideal partner for a hemorrhoidectomy. With a dose of 2 TDS for 4 days, 2 BD for 3 days, you will get an inflammation-free and bloodless access to the site of surgery. For varicose patients with a dose of 2 tablets daily for 3 months, you can provide rapid relief from symptoms such as leg pain, night cramps, and sensation of heaviness. In type 2 diabetic patients, Dimecron MR60 achieves potent HbA1c control up to 6.5% without compromising hyposafety. Cavasil provides a stronger BP reduction compared to other RAS inhibitors.
Our people, our partners, our technology, the foundation to world-class healthcare. Emma Pharma, service for health.
Welcome back. As the third session, we have the first symposium on recent advances in hematology, bench to bedside. I cordially invite the co-chairpersons for the session, Dr. Sarath Kularatna, Senior Lecturer in Obstetrics and Gynecology, Faculty of Medicine, University of Ruhuna, and Dr. Rohan Pullaperuma, Consultant Hematologist, Teaching Hospital Karapitiya, to the head table.
Good evening, everyone. As you all know, this is the third session of the first day of 80th annual academic sessions of Gold Medical Association. So we are going to hear few talks on recent advances in hematology. So we have three eminent speakers for this session: Dr. Chandima Thevaraperuma, Dr. Manu Vimalachandra, and Dr. Nadishani Edirvikrama. Here, you can ask questions at the end of all three presentations, not at the end of each presentation. So when you have questions, you can type your questions in the Q&A box. You can't ask questions directly orally, or you can type it in the chat box. And if you are a panelist, you have a special permission. You can raise your hand and unmute your mic, and then you can put your question. Let me introduce the first speaker. She is Dr. Mrs. Chandima Thevaraperuma. She is working as consultant hematologist at Lade Ridgeway Hospital for Children in Colombo. So she will talk on update on hemophilia care in Sri Lanka. Dr. Chandima, over to you.
Good evening, everyone. I'm Dr. Chandima Thevaraperuma, consultant hematologist at Lade Ridgeway Hospital for Children. First, I would like to thank Gold Medical Association for giving me this opportunity to share my experience in managing hemophilia patients in Sri Lanka. Is my agenda. Hemophilia. It's an X-linked recessive congenital bleeding disorder. There are two types, hemophilia A and hemophilia B. Hemophilia A is due to deficiency in factor 8, and hemophilia B is due to deficiency in factor 9. When you look at early references, the word hemophilia first appeared in a book written by Hoff in 1828. Hemophilia has been also called royal disease because Queen Victoria of England was a carrier. Two of Queen's daughters were also carriers, and they passed the disease on to Spanish and Russian royal families. When you look at the epidemiology, frequency is 1 in 10,000 live births. Hemophilia A is more common. 80 to 85% patients are of hemophilia A. 1/3 are due to new mutations. So males are affected as it is an X-linked disorder, and females are carriers. But there are female hemophilia patients. We have about 11 in our country. And this is due to if a female carrier marries a affected male, their offspring is a hemophilia patient. It's possible to be a hemophilia patient. And then the Turner syndrome and an inactivation of X chromosome, that is extreme lionization, also can give rise to a hemophilia patient. When you look at Sri Lankan data, we have 1,136 registered patients at the end of 2020 December. Out of that, 80% are hemophilia A patients, and hemophilia B patients 221. And we have about 88 patients with factor 8 inhibitors. And our expected prevalence is 2,000 when you consider the population. I think we have diagnosed about 1,136. This difference is mainly due to the mild hemophilia patients, because they don't present to the hospital unless they they get a severe bleeding episode with accident or like injury. Otherwise, usually they don't have spontaneous bleeding. So we do not see them oftenly. So they are underdiagnosed. At the moment, we have 13 hemophilia centers. These centers are capable of diagnosing as well as treating patients as outpatients. Like they have day units. So they treat the patients and then they send them home. So goal of hemophilia care in Sri Lanka is a functional cure, because we do not have a permanent cure. For that, to achieve this functional cure, you have to have early diagnosis, very early prophylaxis before joint damage, and adequate management of breakthrough bleeding. To achieve that, it's a comprehensive care. No one can single-handed manage these patients. It's a teamwork. So we have to have hematologists, medical officers, laboratory technician for diagnosis, nursing officers, social workers, then the orthopedic surgeon for some patients needs knee replacements, then they come with pseudo tumors in bones for that orthopedic support, then psychiatrist, because they have a lot of these patients are, some patients are overprotected and these kids are very aggressive sometimes. So psychiatric referrals sometimes we do. And physiotherapy, that's very important because these patients needs physiotherapy, continuous physiotherapy. That is something which really we have to address on these patients. So let me begin with a case and my presentation based on this patient. So this is a master UD, is a 5.5-year-old boy with a family history of hemophilia A. He presented at the age of 5 days with an intracranial hemorrhage. So as he's having a family history, directly we did the factor 8 levels. So it was 1.1%. And his initial ICH was treated and he was started on weekly prophylaxis that he was given 20% weekly. At the age of 1 year, again he presented with fits. So then again, intracranial hemorrhage was suspected, because when they get one episode, they tend to get intracranial episodes repeatedly sometimes. So suspected and 100% factor correction done, and then CT brain was arranged, which showed left-sided porencephalic cyst formation and volume loss due to previous hemorrhage. There was no new hemorrhage. So he was not continued on factor replacement, and EEG showed abnormal epileptiform activity, and so he was started on carbamazepine. This is his CT scan. You can see this large cyst formation. So let me just explain about management of intracranial hemorrhage. This is very important because this is a medical emergency. If you suspect the intracranial hemorrhage, don't wait for evaluation. You have to start on treatment. So first thing is treat with factor replacement and then start your evaluation if you suspect an ICH. So factor replacement also you have to go for a higher value, higher levels. So usually 80 to 100% factor correction done. How do you calculate the correction? Is the body weight need to, if you need 100% correction, if the patient having less than 1%, so you calculate body weight into 100 and you divide by 2 for factor 8, but for factor 9, you just multiply, you don't divide by 2. And after that only you arrange imaging. Now, if the bleed is confirmed, you continue the same dose, either 3 times a day or twice a day. So it depends, it's an individualized treatment. You can't just say how to use it, but you, depending on the size of the bleed, depending on the patient's GCS, and depending if you're whether you're planning a neurosurgery, depending all those things, you decide on whether you're going to give 8-hourly or 12-hourly. Usually first day we give 8-hourly. In other countries, they do the factor levels, but we are unable to perform factor levels that frequently. So what we do is we try to give 8-hourly first day, and then next day, depending on the response, depending on patient's clinical condition and size of the bleed, you reduce it to twice a day, because factor 8 half-life is 8 to 12 hours. And then the continuation, the same dose you continue 4 to 7 days. That's also you decide. That is all. These are individualized, so you decide on depending on the size of the bleed and patient's consciousness and response to therapy. So after that, you reduce the dose and continue up to 14 days daily dose we have to give. But after that, whether you're going to give for 21 days depends on patient's condition again. So you can stop it at 14 days and start on prophylaxis, or you continue for 21 days. So anyway, after intracranial hemorrhage, they should be on continuous prophylaxis. So what is prophylaxis? Prophylaxis is a regular intravenous injection of factor concentrate in order to prevent bleeding. So the objective of our prophylaxis to convert a person with severe hemophilia to a moderate or mild hemophilia. So we have to maintain factor levels above 1 to 3% at all times, because if it is a moderate hemophilia, it has to be above 1%. To make it a mild hemophilia, above 5%. So it depends on your availability of factor. At least they should have above 1% factor levels to prevent spontaneous bleeding. But sometimes they can develop, even moderate hemophilia patients present with spontaneous bleeding. So it has to be maintained above that level. So there are different regimens. So high dose prophylaxis, that is 50 to 80% correction every 2 days. That is not possible in a country like ours. So intermediate dose prophylaxis is 30 to 50% correction 3 days per week. And low dose is 20 to 30% correction 2 to 3 days per week. So what we do is we give low dose prophylaxis. That is also most of the time we give once a week. And some patients, depending on their bleeding, we increase to 2 days per week. So always that is also individualized. Especially for very small children, you have to start with less intense prophylaxis, like once weekly infusions, and gradually increase the frequency depending on their bleeding, because venous access issues are there, and for them to accept this. When you start on prophylaxis, it's IV injection. So some kids are really scared of injections. So for them to get used to it, usually you start it once a week. And then slowly, if they're presenting with bleeding, then you increase your frequency at least for twice a week in a country like ours, if their frequency of bleeding is high. And other important thing is you have to round up your dose to the nearest vial size. Now, if it is if the vial is 250 international units, and your dose when you calculate it, if it is 200, but you give 250, like that, if they're taking the vials home and taking it from outside. Because some patients, we issue factor 8 vials from them to have it at home and inject from the nearby GP, or if the parents are capable, they can give it at home. Some parents are doing it. And young adults, they inject by themselves. So those things are possible. So you have to calculate to the nearest vial size. And then, but when they come to our unit, as we are sharing it, we use the correct dose because we can share the vials with the other patients. We get them down on 1 day for prophylaxis. So like 2 or 3 days we have, we get them down for prophylaxis, and so they can, then we share the vials. So when I come back to my patient, he presented, then he, at the age of 2 years, he started presenting with recurrent episodes of bleeding. Then we did the inhibitor screening, and factor VIII inhibitor was detected. And we did Bethesda levels, it was 34. Then we had to, if they have inhibitors, we have to stop prophylaxis. We stopped the prophylaxis, and we repeated the inhibitor levels 3 months later. His bleeding episodes were managed in between with activated prothrombic complex concentrate, which is called APCC. So what are those inhibitors? When hemophilia patients are exposed to factor concentrates that they are missing, their immune system may see it as foreign protein and develop neutralizing alloantibodies called inhibitors. There are low titer inhibitors where the Bethesda level is less than 5 Bethesda units. They may be transient and disappear spontaneously without specific management within 6 months of initial documentation. But for bleeding, if these patients present with bleeding, you can use a higher dose, like usually 3-fold higher dose to arrest bleeding. But you can use factor VIII, and you have to monitor closely for anamnesia. Now, if a patient needs 40% correction for a joint bleed, we have to give 120% correction in a patient with low dose inhibitor. High dose inhibitors are when the Bethesda unit is more than 5 Bethesda units. For minor bleeding, you have to use, you can try with local hemostatic measures, tranexamic acid, but if they fail, we have to, or inadequate, we have to use bypassing agents like APCC or recombinant factor 7A. So you can look at that FIBA has 2, 7, 9, 10 inactivated form as well as activated form. It's very bit thrombogenic because it acts at several places bypassing factor 8. Recombinant factor 7A acts it's in the tissue factor pathway. It will directly activate factor 10A, but FIBA acts at several places. So to arrest form clot formation, and it is bit thrombogenic therefore. So when they develop inhibitors, usually we have to try to eradicate these inhibitors. For that, what we use is immune tolerance induction, which is called ITI. That is regular infusions of variable doses of factor VIII, and you have to administer for months to years to tolerize them. So there are several protocols. There's a high dose regimen where you use 200 international units per kg daily, and low dose regimen you use 25 to 50 international units per kg 3 times a week. So what we usually do is 3 times a week low dose regimen, because daily it's very difficult to use daily in small kids because of the venous access issues. If we have to use daily, we have to have a central line port inserted for these kids. So most of the time we try to use low dose regimen. So for our patients, 4 months after the diagnosis, we started him on ITI, and we used extended half-life factor. It's a recombinant product, and we got that as a donation. So we started using it on him, and we used the low dose regimen where he has to come 3 times a week for injections. So just to explain you these extended half-life products, there are several products for factor 8, but increase in half-life is only 1.5 times. For factor 9, it is 3 to 5 fold. Now, if you are using this product for prophylaxis, still for ideal prophylaxis, we have to use twice a week at least. But for factor 9, you can use it once a week because there's a 3 to 5-fold increase in half-life. So ITI was continued for about 2 years, but he did not respond. I mean, we monitored his Bethesda levels. He did not respond. And we decided to stop his ITI. And during this period, he presented with multiple bleeding episodes. So these episodes were managed with APCC. And due to limited resources, we couldn't start him on APCC prophylaxis. So in some other countries, they start them on APCC prophylaxis, but we couldn't start him on, but luckily he didn't develop any intracranial hemorrhages, recurrent intracranial hemorrhages, only the soft tissue hematomas and joint bleeds. So what are the other options available for a patient like that? Then comes this newer therapy, non-factor therapy called emicizumab. This is a bispecific monoclonal antibody that bridges activated factor 9 and 10 to replace the function of missing factor 8. So it's like this is factor 8 and this is emicizumab. It's just like that. It bridges the activated factor 9 and 10 and it's activate factor 10A. So these inhibitors will not act on emicizumab as it is not factor 8. So several trials have gone through, this drug has gone through several trials. And this was published in New England Journal of Medicine, where they have shown that in this trial, there's a marked reduction in bleeding episodes and due to after starting emicizumab prophylaxis. These are the patients who were not given emicizumab prophylaxis, and these are the patients who were given APCC in the past and then switched on to emicizumab prophylaxis. So it's nicely seen that there's a marked reduction in bleeding episodes. The main problem with this drug is it's thrombogenic, but mainly if you use with APCC, because in these 2 trials, Haven 1 trial, that was the first trial, they encountered thrombotic microangiopathy and venous and arterial thrombosis in patients who were exposed to APCC. And other minor side effects like injection site reaction, headache, joint bleeds were there, joint pain. But main worrying is the thrombotic microangiopathy and venous arterial thrombosis. So for our patient, we started him on emicizumab. It's given subcutaneous, so it's there's an added advantage of because no need of venous access. And when you are using that, you have to use first the loading dose that you have to give weekly subcutaneous injection. After that, maintenance dose once in 2 weeks. But later on, like because he was because of the COVID, they were unable to come to the hospital frequently. So we decided to go to once in 4 weeks regimen. But you have to give injections to 4 sites. But later on, he accepted it. He said it's okay for him. So now he's on once in 4 weeks regimen. And now he's very active and leads a near normal life, because I call it near normal. Still, we can't allow them to go for contact sports, high risk situations, because usually when you give emicizumab, their factor levels, like it's not the factor levels, but it's equivalent to 30% factor levels, their protection. So therefore, like you can't ask them to go for that sort of games like contact sports, but they can run around and play, and he's very happy. And he after starting, his bleeding was 0. So this is him. I'm showing him with the permission from him. he used to come mainly with this sort of hematomas because he's very naughty. And management of then the bleeding episodes while on emicizumab. These patients, if they're having inhibitors, prefer to give recombinant factor 7A over APCC. As I told you earlier, APCC, if you give with emicizumab, there's a risk of thrombotic microangiopathy. But if recombinant factor 7 is not available, then the maximum dose which you can give is 100 IU per kg per day of APCC. That is also 1 day you can use it, but you have to monitor for thrombotic microangiopathy. And patients without inhibitors, if you are using emicizumab, you can manage with factor 8. And the patients who are going for surgery, on patients who are on emicizumab also, you can manage with factor 8 if they do not have inhibitors. This is another patient whom we managed a minor surgical procedure who was on emicizumab. He's a 9-year-old boy. He's also on emicizumab once in 4 weeks regimen. And he had a cut injury to his thumb 2 weeks after his emicizumab dose. He did not have any excessive bleeding, so mother took him to a local hospital for a dressing. But his wound was not very healthy, so he needed some surgery at our hospital, and we referred to the surgeon. And then surgeon said, like, for us to manage his hemostasis, then he can do the surgery. We did APTT, it was normal, but you can't rely on APTT if the patient is on emicizumab. Therefore, we did ROTEM, and it was also normal. So we decided for him to go ahead with the surgery without any factor replacement. And this is after surgery. He didn't have any bleeding, and he was discharged from the hospital next day. So when you look at our patient number, we have 32 patients on emicizumab, and we have 22 positive. Out of them, 22 are patients with inhibitors, 10 are without inhibitors. These patients were selected because of one or two had intracranial bleeds, and others were having very high bleeding rate in spite of prophylaxis for 2 to 3 times per week. So they were selected because of that. And then we have on ITI 5 patients, and there are 2 patients who have failed ITI, and ITI completed 4 and still to start 11. These ITI completed patients, still they have to get a small dose of factor 8. Otherwise, their tolerance they can lose their tolerance. So it's always, we have to give a small dose. We continue to give their prophylaxis a very small dose to keep the tolerance. And other thing is whether to start ITI or not in these 11 patients. That is the issue, because in other countries also they are discussing on that, whether it's needed or not. But always we are depending on this donation. This emicizumab is a donation we have got from the World Federation of Hemophilia. So we don't know how long we are going to get the donation. So as the donation is going on, it's always better for us to start on immune tolerance and see whether they can achieve the tolerance. So if they achieve it, it's easy for us because we can manage their intercurrent bleeding episodes. Anyway, these kids, they come with falls and those things. So it's easy for us to manage their bleeding episodes with factor 8. And other thing is, that's the best thing. It's always better if you can manage their bleeding with factor 8 than APCC or factor 7. So therefore, we have to start on these patients also immune tolerance in near future. For our patients who failed ITI, we can't do anything else. So anyway, we have to we have to depend on emicizumab and factor 7 for their bleeding. Now, this is another patient. He's a 9-year-old boy. He had this target joint and he was in pain. He was always coming, like every week they're coming to us. And then when we started this and he couldn't walk, father had to carry him. But after starting, just 6 weeks after starting, his swelling reduced and he started walking. Now he's quite well, running around, doing swimming as exercises, and he's quite happy with the drug. So it's this is because of a donation we are able to give it to the patient, but this is the best treatment available in the world. So our patients are also getting the best options available in the world at the moment. So is there a hope for a cure? That is the other part. Now we are aiming at functional cure, but others are aiming at permanent cure. That is the gene therapy. So they are trying to replace the dysfunctional gene with exogenous functional gene. For that, they have done series of trials and human trials even in phase 3 now. That is the transfer genes through adenovirus associated viral vector, where they have incorporated the therapeutic DNA to the adenovirus and inject it. And then this virus will go into the liver cells and release the DNA, where the DNA will form a episome and produce factors. So it's in trial stage, and we are also trying to incorporate few of our patients to this trial at the moment. That's for the adults. So these are few of my patients who are on emicizumab, and they are very happy about their product, and because they are getting the best treatment option at the moment available in the world for these patients with inhibitors. So thank you very much for listening, and I hope all of you all, when you encounter these hemophilia patients, you will manage them like they will come to you after a fall or that thing. So you have to address them. I mean, you have to treat them quickly, otherwise their joint will get affected if you do not treat them adequately and quickly. So once again, thank you very much for listening, and I'm happy to take up any questions if you have.
So thank you very much, Dr. Chandima, for your update and how do we manage patients with hemophilia in the current era. So as we mentioned before, you can put your questions into Q&A box, and the questions will be answered at the end of the session.
Let me introduce the second speaker, Dr. Manu Vimalachandra. He is a lecturer in pathology, Faculty of Medicine, University of Colombo. He will be talking on state-of-art hematology in diagnostic and treatment. Over to you, Dr. Manu.
Good afternoon. I would like to thank the Golem Medical Association for their kind invitation to be a part of their annual academic sessions this year. So in the next 25 minutes, I'll be talking to you about some new developments that occurred in the past 2 decades in the field of hematology under the title Hematology State of the Art. So the areas I'll be talking to will be next generation sequencing, gene editing, and cellular therapy. So when you talk about next generation sequencing, we can go back to how it all started, the evolution of genetic diagnosis. We can go right to the beginning, where the discovery of the optical microscope, where people actually tried to look at the microscopic features within a cell. Then the landmarks were the description of the laws of inheritance by Mendel, the description of the DNA structure by Watson and Crick. And in the late 1950s, the description of the number of chromosomes in the human cell through the demonstration of a karyogram or a karyotype. Then Sanger sequencing came into being in 1970s, which was further facilitated by the development of PCR, a form of amplification of DNA. And towards the 1990s, the late 1990s and the early 2000s, this concept of next generation sequencing came into being. So next generation sequencing is not a single test. It's a sort of a catch-it-all term that uses several newer DNA sequencing technologies, which uses different platforms, different machines, but essentially what they all do is that they are able to sequence large amount of data in a massively parallel manner, so that at the end of the day, you have a very cost-effective and a quick test to give you information on the sequence of areas of DNA. Now, like I said, there are so many different platforms, but what is common to all platforms, or the general principles of it, would be the spatial separation or the sample preparation, amplification, parallel sequencing, and bioinformatics. Now, I don't have the time or the expertise to go into detail about next generation sequencing, but to very briefly explain what it is. So if you look at Sanger sequencing, which is still the gold standard of sequencing, it essentially uses, you have a particular part of DNA which you need to find out what the sequence is, sequence of the nucleotides are. You have a primer, and to which you add dideoxynucleotides, which are fluorochrome tagged. And when these are added, they will stop at different levels. So at the end of the day, you will have lots of oligonucleotides that are separated through capillary electrophoresis. And on that capillary electrophoresis, you'll have the different colors, and depending on the colors, you'll be able to identify the sequence of that DNA. Now, the difference when it comes to next generation sequencing is, like I said before, first you have to make the samples, or you call that preparation of a DNA library. So fragments of DNA with adapter molecules on either side of them. These molecules are fixed to a solid phase, depending on the platform. And from there, it is amplified. And into this amplified DNA is added, again, fluorochrome labeled nucleotides. And they will bind in the presence of other polymerases and so on, bind to the DNA. And at the end of the day, you will have an image like this, which through the camera, you can identify the sequence. So you have large amounts of DNA sequences coming out. In order to make sense of this DNA sequence, you need what is called bioinformatic pipelines. Essentially, what they do is they take a particular DNA sequence and compare it with a reference DNA to find out what it is most likely to be, or what it resembles the most. Now, I'd like to take from the field of hematology the inherited bone marrow failure syndromes to demonstrate how NGS has changed how we diagnose and manage these conditions. Very broadly, we can divide the inherited bone marrow failure syndromes to the syndromes that are caused due to defective DNA repair. Example is Fanconi anemia. Then you have the telomeropathies, defective telomerase activity or failure to maintain the telomere length. And the example is dyskeratosis congenita, where there is sort of fast forward aging. And then you have the ribosomal pathies like Diamond-Blackfan anemia and Shosman-Diamond syndrome. And then there's a whole mixed bag of other bone marrow failure syndromes, particularly affecting certain cell lines like the megakaryocytes or the neutrophils. A common feature to all of these is that they end up with MDS or ML, and also they have multi-system involvement, so lots of defects and abnormalities and other systems as well. Now, the basic way or the usual way, the usual approach towards a patient like this would be when a patient presents with bone marrow failures, commonly a pediatric patient, but not always. Sometimes there might be a family history, and you do a thorough physical examination, and you might find out these features, skin rashes, rhythm abnormalities, and so on, and then you suspect could it be Fanconi's anemia. Then you do a chromosome fragility test to demonstrate the defective DNA repair in this patient, and if it is positive, you go on to perform a specific DNA sequencing. Now, as time went on, they had found more and more amount of gene mutations, particularly when it comes to Fanconi anemia. It's about 15 mutations. So the next step of this would be to do what is called NGS panel. So a panel that will look at all the possibilities of all the different bone marrow failure syndromes. Now, typically a panel will have about 90 to 100 genes analyzed, and the results will be available in about 2 weeks' time. And the cost of it will be about 50 to 60,000 rupees. This is a paper that was published in earlier this year from Australia, where they looked at 115 patients who presented with possible inherited bone marrow failures. And they, on these patients, so they went through the traditional approach of history examination and the traditional screening test we talked about. And then they did the NGS panel, which I showed to you before, about 90 to 100 genes. And what they found out after doing this NGS panel is 30 out of 115. So almost 1/4 of the patients, the diagnosis completely changed. So that, I think that emphasizes or kind of highlights how NGS has an impact on the diagnosis of these different conditions. What about treatment? The choice of treatment. So if you have a more precise diagnosis, the choice of treatment will be more precise. You can give targeted therapy, especially when it comes to immunodeficiencies. Most of these bone marrow failures will require hematopoietic stem cell transplant, but not always. Even supportive care. Recently, there was a child who with a bone marrow failure with a particular mutation called SAMD9. In this particular mutation, there is, in addition to bone marrow failure, there's an element of immunodeficiency as well. So when he presented with neutropenic sepsis, in addition to treating with antibiotics and antifungal, we also did immunoglobulin levels, and it was found to be extremely low. So in addition to the conventional method of managing neutropenic sepsis, we also treated it with immunoglobulin replacement, which finally resulted in a good outcome. Then if the treatment is hematopoietic stem cell transplant, finding an optimal donor. Now, the ideal donor for any hematopoietic stem cell transplant would be a matched sibling donor. However, when you know the patient has a particular type of mutation, we can see if that particular mutation is also present in the sibling, because the sibling can be completely normal, morphologically completely normal, with normal blood count, but still harboring that particular mutation. So if you transplant the patient with that sibling, the patient is eventually going to end up with the same diagnosis. Then when you find a proper donor, choosing the optimal conditioning regime. And because these conditions, bone marrow failure syndromes, have a multi-organ involvement, they will have increased risk of lung fibrosis, secondary malignancies. We can fine-tune the chemotherapy or the radiotherapy we give in the conditioning to have minimal risk depending on the particular organ involvement of that particular syndrome. Then identifying at-risk family members. We can do family screening, family counseling, and once we found which family members are risk and the patient, we can have disease-specific surveillance. So screening again for lung fibrosis or secondary malignancies can be done in a very systematic manner when you know what particular mutation that patient is harboring. Right. So moving on from next generation sequencing to cellular therapies, I always start the talk with the story of this little girl called Emily Whitehead. So she's a girl from Philadelphia who was diagnosed with B, acute lymphoblastic leukemia in 2001, 2002, somewhere around that time. As you probably know, ALL has a very good prognosis in children with 80 to 90% cure rates. Unfortunately, Emily fell into the category of the unlucky 10%, where she was resistant towards the first line of treatment. So she received the second line of chemotherapy, which she was resistant to as well. Now, even to proceed towards a bone marrow transplant, you need to get some sort of disease control. So the only options available for her at that point was palliative care. But in that particular hospital, the Philadelphia Children's Hospital, there was a clinical trial. They were trying out this new treatment called CAR T cells, where they were using the patient's own immune system to fight malignancies, which has never tested in humans. So she was enrolled in that trial. Before we come to this CAR T cells, something called immunosurveillance. What is immunosurveillance? Basically, it is a very important function of our immune system, that is to recognize and irradiate tumor cells when they occur inside a normal human being or any living being for that matter. Now, we know malignancies are common in immune deficient people. However, majority of tumors do occur in people who are immunocompetent, which tells us that the tumors probably try very smart methods to evade the immune system from this natural surveillance system. And one of the ways is to hide from the immune system so that they are not recognized. So that's where the CAR T cells come, and CAR T therapy comes from the name stands for chimeric antigen receptor T cells. So chimera, as you know, is an animal who has a head of a lion, the tail of a snake, and the body of the goat, or so on and so forth. But essentially what happens is, so you have the patient's T cell, which is not recognizing the tumor cells. To that, genetically, they, through the use of a viral vector, they insert a new T cell receptor. So essentially this T cell is a chimera now. It doesn't have its original T cell receptor, but it has a modified T cell receptor. How is this T cell receptor modified? It is specifically designed to recognize the B lymphoblast. So CD19 is a surface molecule that is found on B lymphoblast, and this new T cell receptor is able to bind to the CD19 molecule. Not only does it bind specifically to CD19, the receptor is modified further to make its natural killing ability more potent. So we have a more potent and more specific T cell. So how is this made? So you have the patient undergoes leukapheresis, just as you have plasmapheresis and so on. And you take out the T cells, and the T cells are manipulated in vitro using viral vectors. They are inserted with this new T cell receptor, then they are expanded, and once they are expanded, they are put back into the patient. Now, it was a huge deal at that point. The journal Science called it the cancer immunotherapy, and it was a huge deal for this little girl who responded completely. And she went on to found this foundation called Emily Whitehead Foundation which raises money for cellular therapy, specific cancer research involving cellular therapies. So if you go to the website, you'll see everywhere she puts a picture which says she's free of cancer. So she's now 9 years free of cancer. Her efforts as a cancer survivor and as a person who raises money for cancer research were recognized by the President of the United States. And it so happened that she was invited to see him on a Tuesday. And President Obama, being the cool guy he is, gave an excuse letter to the teacher, excusing because she was with the president. Right, so where are we now? It has come a long way, almost 10 years for the CAR T cells now. So BLL, as I mentioned, has a very good response rate, but this is short-lived. So this can be used as a bridge towards hematopoietic stem cell transplant. Then the main news right now is in the B lymphomas. So 1/3 of B cell lymphomas consist of diffuse large B cell lymphomas, and you have about 80% overall response rate. And in more than half the patient, this response is maintained. Remember, all these diseases are not de novo. These are refractory, relapsed refractory ones. So they have undergone multiple lines of chemotherapy, and only when they are resistant to multiple lines of chemotherapy can they be eligible for this experimental, very costly treatment. So if you think of multiple myeloma, there's a 73% response rate. So these are patients who have got 6, 7, or even 9 to 10 lines of chemotherapy before being treated by CAR T cells. So these are good numbers if you are a patient who has gone through all of that. Right. So what is the future? What holds the future for CAR T cells? So CAR Ts they are trying to make them even smarter and even better. So two essential features of these CAR T cells. One is their ability to kill the tumor cell, the tumoricidal activity. So that can be enhanced not only using the T cells' ability to kill the tumor, but also using the surrounding cells. So the trucks are a form of new CAR T cells where not only the T cell, the CD8 positive T cell, but it also secretes cytokines so that it uses all the other elements of the immune system as well to fight the tumor cells. Now, off-the-shelf CARs, which is a big hot topic. Now, the type of CARs we discussed before are what are called autologous CAR T cells. So you have the patient's own T cells being taken out and shipped to a lab about hundreds of thousands miles away, and it's manipulated and amplified there, and it has to come back again 1,000 miles to the patient. So this takes a long time. There can be mishaps in between. So what if you had allogenic CARs or off-the-shelf CARs? You can just give those CAR T cells as you would give a normal blood transfusion. So all of the previous CARs were T cells, but now the NK cells are also being tested, and they have their own advantages when compared to a T cell. Cost and availability. One of the main criticisms of CAR T cells is that the huge cost. If you take the cost not only to manufacture the CAR Ts, but from the point of the decision to administer the whole workup to give the CAR Ts and to administering it finally and the follow-up, the cost is about $350,000 US. However, Japan and China are now coming to the market, and China and India. And India have actually said they are ready to recruit their first patient to their CAR T trial this year. And they say they'll be able to afford to give this treatment for a cost of 50,000 USD, which is essentially the price of an allogenic stem cell transplant. So a treatment which is sort of science fiction is really now at our doorsteps, and our patients should be able to hopefully access this very interesting treatment. Coming on to the last topic, which is gene editing. This is a paper, a landmark trial that was published in the New England Journal of Medicine earlier this year, where the results of gene editing in two patients, one with sickle cell anemia and the other one with beta thalassemia, was published. And these patients, the one with sickle, had about more than 3 acute sickle cell crises per year, whereas the beta thalassemia patient was receiving at more than 10 transfusions. So what is shown on the screen were the eligibility criteria. So what is gene editing? So gene editing essentially tries to correct an acquired or congenital genetic defects. There are many platforms that you can use it, that you can use to do this, but CRISPR-Cas9 is the most popular platform that is kind of coming above the other platforms. So what is CRISPR-Cas9? CRISPR-Cas9 is actually an endonuclease which cuts the DNA. So it basically cuts it like a scissor, and it is tagged to an RNA which guides it to where it should go. So it is originally coming from a bacteria. It's a sort of a immune response of a bacteria towards a viral infection. But the CRISPR-Cas9, like I mentioned, is endonuclease, and to the endonuclease is tagged and guide RNA. So once in vitro to a stem cell, this is administered, the guide RNA will take the endonuclease to that particular gene that needs to be corrected. And what the CRISPR-Cas does is it causes cuts, or it cuts the DNA. And once there's a double standard break, the natural tendency of the cell is to repair itself. So the cell keeps on repairing, and the DNA endonuclease keeps on cutting the double standard break till it repairs itself. So once it repairs, the endonuclease stops cutting. And then you have essentially a stem cell that has been completely corrected. And this can be re-administered to the patient. If it's a hematopoietic stem cell, the patient will need some sort of conditioning like a bone marrow transplant, and they will receive something like an autologous transplant. So that is what happened to those two patients, the sickler and the beta thalassemia patient. For the description of this very, very exciting CRISPR-Cas9 system, these two scientists received the Nobel Prize for Chemistry last year. So if you look at the results, the sickle cell patient who started with a hemoglobin of about 8 at the end of 18 months had gone up to 40. And the sickle cell patient who had HbS consisting about 74% of all the hemoglobin went down to 52. So she was converted from a sickle cell disease to a sickle cell trait. And there were no acute crisis for this patient during this follow-up period. And this patient obviously did not require any blood transfusions. So what are the other uses? So two monogenic hematological disorders I mentioned, sickle cell anemia and beta thalassemia. Hemophilia B is another area where there's lots of interest. There's actually a few Sri Lankan patients also now worked up to be enrolled in one of these trials from the National Hospital of Sri Lanka. And immunodeficiencies. There's lots of monogenic disorders with immunodeficiencies that gene therapy is used. Then CAR T cells, the CAR T cells we discussed. So all the fancy changes that you can do to the T cell receptor can be done using this CRISPR-Cas system. HIV, another exciting area where gene therapy is used. So they try to get rid of the receptor that is required for the HIV virus to enter or infect the cell. Mucopolysaccharidosis is another disease where there's most recent trial data coming out where the cells were infected with the viral vector that resulted in the editing of the gene. Right, so what are the challenges? One is off-target editing. So it's all well and good if it goes and corrects the right place, but I mean, while correcting the hemoglobin, it also takes out the phagocytic activity of a neutrophil, I mean, that's not something that you would desire. Then achieving sustainable cell populations in vivo is difficult of the genetically modified cell, because obviously you want 100% of that cell working, which can be a challenge. Most of the hemopoietic stem cells that are edited will require myeloablation. So all the complications of an autologous transplant will also be there when there's gene editing. Ethical issues, it's a huge problem, which was highlighted when there was embryonic gene editing by Chinese scientists. Surprise there. But so what he actually did was these twin girls were born whose mother was HIV positive, and he manipulated the embryos so that they would not be infected. He claimed that it was successful, but it opens up doors to ethical issues. So basically you can end up creating superhumans. Probably they have already, who knows? And you'll end up like something like what happened in Jurassic World, where they made this very super nasty dinosaur called the Dominus Rex, putting together all the nasty features of all the dinosaurs, including the pit viper venom of our own green pit viper. Right, so I think that comes to the end of my short talk. Once again, thank you for your patient listening and the very kind invitation. Thank you.
Thank you very much, Dr. Manu, for very comprehensive talk on behalf of the GMA and the BMA committee.
So we are coming to the last part of our symposium, and that will be done by Dr. Nadishani Drivikrama. She's a consultant hematologist and working at Castle Street Hospital for Women, Colombo. So over to you, Nadishani.
Good evening, everyone. Let me first of all thank Goal Medical Association for inviting me to deliver a talk on obstetric hematology. So when I was looking for a topic, I thought it would be interesting to talk on hematological manifestation of COVID-19 infection and how it changes during pregnancy, as it's a hot topic these days. So it's no need to say that COVID-19 has become a global pandemic, and it's caused by SARS-CoV virus 2. And up to 1st of September, total exceeding 217 million cases were reported globally, and the deaths exceeded 4 million. And up until 31st of August, in Sri Lanka, total of cases exceeding 400,000 were reported, and the death toll reached 9,185. This included 28 maternal deaths. And you all know that most of these affected individuals are asymptomatic or mildly symptomatic. Only 1/5 of them become severely ill, and 2 to 5% will die. And they die of complications, particularly with regard to pulmonary system, respiratory system, and also they might experience complications related to hematology, neurology, cardiac, or renal complications. And it is found that this virus enters the body via angiotensin converting enzyme 2 receptors, which is more prevalently found in lung tissue. And moving on to hematological manifestations, there are many publications discussing hematological manifestations of COVID-19 infection. And this recent review article that appeared in European Journal of Hematology discusses many hematological manifestations. Of them, I would like to discuss further on cytopenias, and coagulopathies mainly. So my talk will be on, I will be discussing on cytopenias, coagulopathy, plus or minus thrombosis. In the sense, coagulopathy may be associated with thrombosis or not. And finally, I would like to touch briefly on VITT, even though it's not directly related to COVID-19 infection. Since with the ongoing vaccination program, I thought it would be timely to discuss few things about vaccine-induced thrombocytopenia and thrombosis as well. So moving on to cytopenias, the commonly reported cytopenia is lymphopenia. In many articles, they discussed about lymphopenia. And also, the next common list would be thrombocytopenia, which is again mild. Anemia is also reported, however, it does not have much of a clinical significance and usually mild. And this review article, submitted by a Sri Lankan group, appeared in American Journal of Tropical Medicine recently, analyzes recent evidences of with regard to hematological manifestations and came to these conclusions. They also found lymphopenia as the commonest hematological manifestation, and then about 20 to 40% has had leukopenia as well. And a smaller proportion has had leukocytosis, particularly neutrophil leukocytosis. And neutrophil leukocytosis is not something to be surprised, because when secondary bacterial infection sets in, or when cytokine storm is there, with the massive inflammatory, when there's massive inflammatory response, you can get neutrophil leukocytosis. And also they have seen 5 to 21% of patients were getting thrombocytopenia, and as I said earlier, thrombocytopenia was mild. So how do they get lymphopenia? So there are many mechanisms that they describe. The most favored one is lymphocytes too have ACE2 receptors. So via these receptors, lymphocytes may enter into the cells and thereby may cause apoptosis, and invasion of the reticuloendothelial system may cause destruction of lymphocytes. So you may experience metabolic acidosis in COVID-19 infection, and raised lactic acid levels are known to cause reduced proliferation of lymphocytes. The primarily affected organ is lung, so lymphocytes may traffic towards the lung, causing peripheral blood lymphopenia. Also, there are so many evidence suggesting or showing the strong association between lymphopenia and severity of COVID-19 infection. In turn, it's associated with the prognosis. The next commonest is thrombocytopenia, and again, this is associated with high risk of mortality. So this study evaluated the degree of thrombocytopenia among survivors and non-survivors and compared. So this continuous line represents the non-survivors, whereas this light-colored line shows survivors. So you can clearly see the difference between the platelet count between the survivors and non-survivors. And similarly, this graph shows that when the severe the thrombocytopenia, the mortality goes up. So what could be the cause for thrombocytopenia in COVID-19 infection? So there are many causes that they have postulated. As in any viral infection, COVID-19 itself can cause thrombocytopenia. And COVID-19 is well known to associated with DIC, which is another cause for thrombocytopenia. Also, as in other viral infections, COVID-19 also known to associate with antiphospholipid syndrome and immune thrombocytopenia, all are immune-related complications, which are causes for thrombocytopenia. Also, when the cytokine storm sets in, hemophagocytic syndrome can occur, which is a cause for cytopenias. Also, these patients are treated with heparin, so they might get heparin-induced thrombocytopenia. So another cause would be the drug-induced myelosuppression, which can be caused by the antiviral drugs that is given to these patients. And finally, pseudothrombocytopenia is also known cause because several publications show the evidence of EDTA-induced aggregation, platelet aggregation in these patients. You all know we collect samples for full blood count in an EDTA sample, which is the purple top tube. So the anticoagulant there is EDTA, and it's known, there's known reaction between EDTA and platelets, which is again antibody mediated, and which is more prevalently found in COVID-19 infection. So what happens here there is, so because of this aggregation, the machine full blood count analyzer reads lesser number of platelets than what is actually there. So that's why we call it pseudothrombocytopenia. So moving on to anemia. So anemia also can be seen, and it's thought that it's because of COVID-19 infection virus attacking the beta chains of the hemoglobin. And reduction of this hemoglobin may adversely affect on respiratory distress. The other main area would be coagulopathy. So changes can be mainly observed in D-dimer, fibrinogen, PT and APTT. And it's well known that the COVID-19 infection is a thrombogenic condition, and one publication showed that there's a 3 to 6 times higher rates of thrombosis in COVID-19 infection. And the mechanisms that they think is because the inflammatory response may disrupt the balance between the anticoagulant and procoagulant pathway, and as a result, the procoagulant pathway gets prominent. And also they have found the von Willebrand factor is increased in COVID-19 infection because of the endothelial damage. Why the endothelium gets damaged? They think it's because there are cells called pericytes beneath the endothelium which contains ACE2 inhibitors. So these cells may be attacked or affected by COVID-19 virus, and which may in turn lead to endothelial activation and stimulation, also damage, which can lead to a procoagulant status. So it is also found that PT and APTT can be prolonged in certain number of patients with COVID-19 infection. And also, more importantly, it is found that there's an association between the rising PT and APTT with the severity of the disease. Also, COVID-19 can affect liver, so PT is also useful marker to assess the degree of liver failure. APTT prolongation is also seen, and it's thought one reason could be the presence of APLS antibodies. And also APTT is used to monitor the action of unfractionated heparin if patients are on. And however, there's no clear data with regard to the pregnant population, how these parameters behave in this among the pregnant women. And this study shows how the PT, the coagulation parameters like PT, APTT, D-dimers, FDP, fibrinogen behaves among survivors and non-survivors from this disease. So the survivors are shown in the blue lines, by the blue lines, whereas the non-survivors are shown by the red line. So you can clearly see the non-survivors has had raised PT, APTT, D-dimers, fibrinogen degradatory product, which is again something similar to D-dimers, and fibrinogen. All were elevated among non-survivors. So there's a clear relationship between the elevation of these parameters with this disease severity. Okay, so moving on to D-dimer. So D-dimer is increasingly being used in this group of patients, and it is it's found that it's most useful consistent marker for identifying the disease severity. And there are many publications to prove this fact. However, there are many reasons for elevation of D-dimers among these patients apart from a thrombus. So infection inflammation itself can be a cause for raised D-dimers, and renal failure can lead to raised D-dimers because D-dimer is excreted via kidneys. And pregnancy itself is a condition where you get high D-dimer levels, and when pregnant patient admits with coming with complications of COVID-19 infection, is baby survivable, they would subject the mother to an emergency section to take the baby out. So some of these patients might be post-LSES patients, which again, a surgery or LSES may be a cause for raised D-dimers. And another reason why these patients, COVID-19 patients, may get raised D-dimer is because of the alveolar damage, they can get fibrin deposition inside the alveoli. So a D-dimer is a sort of a degraded product of fibrin. So when fibrin clot or fibrin clot is degraded, these D-dimers can escape to the bloodstream, causing elevated D-dimers. So there are so many causes for elevated D-dimers. Therefore, you can see that it doesn't necessarily mean or raised D-dimer doesn't necessarily indicate the presence of a thrombus. So it has a poor positive predictive value, but if you get a low D-dimer level, then you can safely exclude the possibility of having a thrombus. So it has a, in other words, it has a high negative predictive value. And so there are many publications saying that D-dimer is not useful to diagnose thrombus, but it will be useful to exclude the thrombus. And especially in pregnancy, where D-dimer is anyway high, it's not useful to detect a thrombus. So this study, which was done in UK among a small number of pregnant mothers who are COVID positive and COVID negative, they have compared the behavior of these hematological parameters among these two groups. And they have found there's a significant difference between hemoglobin, where COVID positive mothers has had a low hemoglobin compared to COVID negative mothers. But there wasn't a difference between platelets and other coagulation parameters except APTT, where APTT was high among the COVID positive mothers. And this study is from China, again compared small group of pregnant mothers was compared non-pregnant mothers who were all affected by COVID-19. And they have shown there's a significant difference between the absolute neutrophil count among compared to non-pregnant mothers versus pregnant mothers. So obviously pregnant mothers will get neutrophil leukocytosis or neutrophilia as a physiological change. So you can't really conclude that this is a COVID-19 related change or not, because this is anyway a physiological finding. Also, they have failed to demonstrate any significant difference between the hemoglobin, platelet and the lymphocyte, absolute lymphocyte count. So compared to the previous study, they have compared all the pregnant mothers who are COVID positive and negative. Here, they are comparing non-pregnant mothers versus pregnant mothers. And there's no significant difference between the platelet count and the hemoglobin. They haven't studied coagulation parameters except D-dimer, which is again significantly raised among pregnant mothers. And as I told, pregnancy itself is a condition where you get high D-dimers. So therefore, this doesn't surprise us. So you now looking at these studies, you can see that you really can't come to a conclusion how these hematological parameters behave in pregnant mothers. I believe more studies needs with a large population. Okay, so thrombosis, as I said, is much common among COVID-19 patients, and it's more common among critically ill patients compared to non-severe disease. And this study has analyzed the nature of the thrombosis, and they have found VTE are much more prevalent compared to arterial thrombosis. And among these VTEs, more or less half were pulmonary embolisms, and 15% were pulmonary embolism plus DVTs. So, in other words, you can see that around 65% were pulmonary related or has had pulmonary embolism. So they have found that there's a preponderance to pulmonary vasculature. Therefore, it's a new term coming up called pulmonary intravascular coagulopathy. As opposed to other diseases or where you get DIC, in other in other contexts, you can see thrombosis everywhere or all over the body, or maybe there is no organ-specific preponderance. However, in COVID-19, you may see a preponderance towards the lung. So this could be because the primarily affected organ is lung. Therefore, there is endothelial activation and damage in the pulmonary circulation, and these are critical ill patients. Maybe they are getting mechanical ventilation and CVP lines. So all can contribute towards getting pulmonary embolisms. So this study, this article describes the hypercoagulability status of the pregnancy mothers. So you all know pregnancy itself is a hypercoagulable status. So why this occur? Because the coagulation factors go up, like factor 7, 8, 10, 1 milligram factor and 5 milligram, and the anticoagulant mechanisms go down. So you can observe decrease in protein S levels and acquired protein C resistance, so which will all cause reduction in the anticoagulant pathway. Also, antifibrinolytic pathway also get the prominences get reduced. So all these factors make the mother more hypercoagulable. So that is a physiological change which is needed, or which aid mother to face the delivery and the blood loss following the delivery. So this study has evaluated thromboembolic complications among pregnant mothers, a systematic review of 69 papers. Altogether, there were above 1,000 pregnant mothers. And in conclusion, they say that the coagulopathy and thromboembolism are increased in pregnant mothers who are affected by COVID-19 infection. So how we are going to manage thrombosis? So if you have evidence of a thromboembolic event, or if there's a higher suspicion, you need to anticoagulate them with therapeutic doses. And also there are some publications showing the benefit of escalating up to therapeutic anticoagulation when there is evidence of coagulopathy, or when there is raised D-dimers. Because in other words, when there's severe disease, they found that there's a benefit of increasing anticoagulation to therapeutic levels. However, this recent two publication sort of gives a different idea. This appeared quite recently in a new NEJM, and what they have done is they have compared or they have analyzed more than 2,000 patients who were having moderate disease as compared to severe disease, and they have randomizedly gave prophylactic dose and compared it with therapeutic dose. What they have found is those with moderate disease, they have benefited with therapeutic anticoagulation, while those who had severe disease benefited from prophylactic anticoagulation compared to therapeutic anticoagulation. So how would you administer thromboprophylaxis in pregnancy? So this the Spanish group recommends to give thromboprophylaxis to all mothers who are admitted with COVID-19 infection, and to continue it 2 weeks following discharge. And for postpartum mothers, they are advised to continue it up until 6 weeks. RCOG also recommends to continue or to give low molecular heparin prophylactic dose when they are admitted, and to escalate it only following the MDT discussion. And they advise to give prophylactic, continue prophylaxis up until 10 days of discharge. For postpartum mothers, it may be continued up to 6 weeks even, depending on the other risk factors of thrombosis. Sri Lankan College of Obstetricians and Gynecologists also adhere to a more or less similar policy, and apart from that, they also advise on TED stockings, and they also another point that they highlight is to stop anticoagulation when the platelet count drops below 50,000. I believe this is a good number to stop anticoagulation, especially if the patient is on therapeutic anticoagulation. If it is prophylactic, we can usually go up to 30, especially during this COVID context. So you may continue it up until 30, it drops up to 30. So finally, let me briefly touch on VITT. This is a sort of a rare occurrence and reported following AstraZeneca and Janssen vaccines. And it's an idiosyncratic vaccine reaction, and the mechanism is more or less similar to heparin-induced thrombocytopenia and thrombosis, where you get platelet activation leading to a thrombus. And it occurs about 5 to 20 days, 8 days after the vaccination, and usually occurs among young population. And it is so because of the mechanism is different, or in other words, it's more or less similar to HIT. It's not associated with other usual risk factors of venous thromboembolism. And also, studies have shown that the pregnancy is not a risk factor to get VITT, pregnancy or postpartum. So they are advised to go ahead with vaccination, irrespective of whether you are pregnant or in the postpartum period. I think that brings to the end of my presentation. Thank you so much for listening. And if you have any questions, I'm happy to take up. Thank you.
So thank you, Nadishani, for that elaborative, expansive, very informative discussion or the presentation on COVID and management of COVID in pregnancy. So as we have finished all three presentations, now this is the question time. I have two questions. The first question goes to Dr. Manu Vimalachandra, and this was from Dr. Lakmal. And his question is, does the CAR T cells react with mature B cells which has CD19? Over to you, Manu.
Oops. Thank you, sir. Can you hear me?
Yes, we can hear you.
Right. Yes. So theoretically, it can work either ways. That is, your CAR Ts can recognize the normal Bs, as well as the B cells can recognize CAR T cells. But practically, that doesn't happen because all patients who undergo CAR T therapy, before the CAR T cells are infused, they undergo a process called lymphodepletion. So they are treated with fludarabine and cyclophosphamide, which are very lymphotoxic chemotherapeutic agents. So essentially, before the CAR Ts are infused, all your lymphocytes are knocked off. So the only CAR Ts that are circulating, the only lymphocytes that are circulating are the CAR T cells. So on in vivo, it doesn't happen, but theoretically, it can happen. Both ways, it can happen.
Yes, thank you, Manu. The next question goes to Dr. Nadishani, and the question is not directly related to COVID. This question is from Dr. Janaka, and his question is, what are the other infections which can cause lymphopenia? Now we know that dengue is a well-known viral infection, and now we just heard that COVID also can cause. What are the other causes of lymphopenia?
I hope you can hear me.
Yes, we can hear you.
Yeah, so the classic example that comes to my mind is HIV. Apart from that, actually, we have seen lymphopenia and other common respiratory viruses that can cause influenzas. So those are the viruses that actually comes to my mind. Apart from that, TB is a known cause for lymphopenia. I think those are the commonest causes, commonest infections that crosses my mind that can cause lymphopenia.
Okay, thank you very much. And I also have one question that is for you. And we know that we routinely do D-dimers, and we all know that D-dimer levels can be elevated in COVID. And in your presentation, you mentioned that the D-dimers are usually used as a negative predictor of thrombosis rather than a positive thing, because there are so many causes which can cause elevated D-dimers. But in our COVID guidelines, the COVID prophylactic guidelines, we know that if the D-dimer level is 10 times higher than the normal cutoff, we ask them to put on an anticoagulant. What is the rationale? Do you have any idea why we have done that?
Well, actually, according to the evidence that I found, we really can't, as I said, it has a negative predictive value, but really, you can't really come to a conclusion that there's a thrombosis just because of high D-dimer. Of course, you may think of, in the sense, you may, how can I say that? You can suspect a thrombus if the patient is not clinically that unwell, despite being well or despite being not unwell, if patient is having D-dimer. Or in other words, if there are no other reasons for the particular patient to get high D-dimers, then of course you may suspect. And as I said, with the initial suspicion itself, you may have to start on therapeutic anticoagulation without waiting for the confirmation. So in that context, I would say yes. But when it comes to pregnancy, where I work, I come across so many so many patients with raised D-dimers, but without any thrombosis, particularly because they are pregnant and most of the time, when they get back, they are subjected to LSCS. So obviously, post-op mothers will get high D-dimers. So therefore, where I work, actually, I really can't come to a conclusive idea with high D-dimers, whether it's really related to thrombosis, especially when at the pregnancy context. Have I answered this?
Yes, thank you. And there's another question, again, that is for you. Some COVID patients shows thrombocytosis, especially during the hyperimmune phase. Would you recommend aspirin for those patients and for how long?
No, what was the evidence that I gathered? Aspirin is not recommended. I would ask Manu also whether you have come across anything different, but according to the evidence that I have gathered, aspirin is not recommended. But some physicians, there has been an argument whether to give from aspirin, but I couldn't find any evidence. And also, thrombocytosis per se, in this context, will be a reactive phenomena. So it doesn't warrant antiplatelet treatment at that moment.
So Manu, do you want to add anything?
Yes, I think I agree with Nadishani. There is no good solid evidence to support the play for aspirin as thromboprophylaxis. And if I can just add something to your question, sir, what you asked about the D-dimers. So in the REMAP-CAP trials, Nadishani showed she showed that the moderate COVID group benefited from therapeutic anticoagulation. So they actually looked at this group and they checked their D-dimer levels. So they divided the ones who had high D-dimers and low D-dimers. If I remember right, the cutoff was about 2 times the upper limit. And the benefit of therapeutic anticoagulation was seen in both groups. So which really emphasizes that there's no place of D-dimer levels to decide on the intensity of anticoagulation. And I think the guideline was also updated recently, which took off the point where we had kind of indicated that you can use D-dimers as a guide to the intensity of anticoagulation.
Rohan, can you hear me, Rohan? Yeah.
Yeah, of course, yes.
Aspirin, we usually use for the post-COVID, like MIS-C, multi-system inflammatory syndrome. When the platelet count is very high, we use aspirin as well as the D-dimers more than 10 times. Even there's no thrombosis. If there is cardiac issues, we start on enoxaparin. So I think for that purposes, because they can come with Kawasaki-like disease in the multi-system inflammatory disorder. So in that sort of cases, we use aspirin as therapeutic, as 75 milligram. Like kids, we use, of course, 3 milligram per kg. So it's something like that.
I agree with that point. In the cardiac, if there's a cardiac involvement, they usually give aspirin, but not thrombocytosis per se. I have not seen giving the aspirin without any other comorbidities in the background.
So in the absence of any other questions, we are happy to wind up the session for that. So thank you very much for the presenters for their excellent presentations and all the listeners for your patience listening. So thank you very much and good night. And we are going to have our inauguration later.
Thank you very much, co-chairpersons. With that, we conclude the academic activities of the first day of the 80th annual academic sessions of the Gall Medical Association. On behalf of the President and the Executive Committee of the Gall Medical Association, I have the pleasure of inviting you to the inauguration ceremony, which will start at 6 p.m. today. The second and final day of the scientific sessions will commence at 8 a.m. tomorrow. Please do join us for a stimulating academic experience. Thank you, ladies and gentlemen, and I hope you have a pleasant evening.
Rockets use supercooled methane and liquid oxygen as fuel. They directly release substances which can damage the ozone layer. Now, with businessmen eyeing space tourism, the damage to the ozone layer may become accelerated. Even fighter jets travel above the ozone layer. With the depletion of ozone layer, we lose the protection it offers from UV rays. Let me tell you few words about air quality index. This measures 5 pollutants and convert it to a number ranging from 0 to 500. Depending on the number, air quality is classified in a range from good to hazardous, along with a color coding. And Colombo, fatality, actions, and so on.
The identification of video as an epidemic in Valisara base camp, and we wanted to do a hydroxychloroquine post-exposure study. The protocol was published, the study was conducted, but unfortunately, the adverse publicity at that time against hydroxychloroquine meant that most of our subjects had not taken the drugs and we couldn't really analyze the data. The other one was an idea which promoted by Dr. Abe Gunasekara, the GU surgeon, and of whether antifilural drug diethyl carbamazine could be used. This was again early stages of the epidemic, and we did an extensive literature search, and we felt that diethyl carbamazine, at least we should think of doing in vitro studies to see whether there are
Torrent Pharma, one of India's leading integrated pharma companies. Torrent Research Center works zealously in the quest to discover better therapeutic solutions. Have to their credit novel drugs that have been developed for the first time in the world for various therapeutic segments. Currently, we operate in over 70 countries across 6 continents. Most respected pharma company.
We have seen that HMOs are components unique to human milk, which are surprisingly very abundant, but devoid of any nutritive function, leading us to wonder what they actually do. Revealing that HMOs play a key role in supporting the immature immune system of infants, thus protecting them at a time of great vulnerability when their defense system is not yet fully functioning. HMOs also help to educate the developing immune system in order to make it fully functional. So, how do HMOs do that? HMOs help the immune defenses in 4 major ways. First, they help establish a protective commensal gut microbiota. Second, they block pathogens from doing harm. Third, they strengthen the gut barrier function. And fourth, they help educate the developing immune system. The more you learn about HMOs, the more you will understand what makes them so specific and beneficial.
Deflon 500, the world's first oral drug with international guideline recognition for hemorrhoidal disease and chronic venous disease. Deflon 500 is the ideal partner for a hemorrhoidectomy. With a dose of 2 TDS for 4 days, 2 BD for 3 days, you will get an inflammation-free and bloodless access to the site of surgery. For varicose patients with a dose of 2 tablets daily for 3 months, you can provide rapid relief from symptoms such as leg pain, night cramps, and sensation of heaviness. In type 2 diabetic patients, Dimecron MR60 achieves potent HbA1c control up to 6.5% without compromising hyposafety. Cavasil provides a strong obesity reduction compared to other RAS inhibitors.
Our people, our partners, our technology, the foundation to world-class healthcare. Emma Pharma, service for health.
gentlemen, it is my great pleasure to welcome you to the inauguration ceremony of the 80th Annual Academic Sessions of the Gaul Medical Association. The Gaul Medical Association, with its long-running history of contribution to academic achievement, has truly shown its commitment by rising to the demanding task of conducting its annual academic sessions amidst a global pandemic, which is challenging humanity in every possible way. As an adaptation to the current circumstances in the country and in keeping with the health regulations, this year, the academic sessions of the GMA will be conducted as a virtual conference with live broadcasting, while bringing together medical professionals and academics of many fields and tiers. To adhere to the COVID-19 regulations, some deviations from our traditional academic sessions were inevitable. To commence with the inaugural proceedings, I now invite you to pay respects to the national anthem. Thank you. It is knowledge that sheds light on our lives. Signifying this, I would like to cordially invite the following dignitaries and representatives for the traditional lighting of the oil lamp. Chief guest, Professor M.D. Lamawansa, Vice Chancellor, University of Peradeniya and Professor of Surgery, University of Peradeniya. Orator GMA 2021, Professor Saroj Jayasinghe, Emeritus Professor of Medicine, University of Colombo and Consultant for the Department of Medicine, Sabaragamu University of Sri Lanka. Vice Chancellor, University of Ruhuna, Senior Professor Sujeeva Amarasena. Dean, Faculty of Medicine, University of Ruhuna, Professor Vasantha Devasiri. Director, Teaching Hospital Karapitiya, Dr. Shelton Pereira. Director, Teaching Hospital Mahamodara, Dr. T.P. Vimalasena. President of the Gaul Medical Association, Professor Sampath Gunawardena. Immediate past President GMA Dr. Kalum Deshapriya. Representing all past presidents of GMA, Senior Consultant Dr. M.K. Raghunathan. President-elect of GMA Dr. Krishant Jayasekara. Joint Secretaries GMA Dr. Upeksha Liyanage and Dr. Varsha D'Souza. And a medical student to represent future GMA, Mr. Sandaru Salvatore of the 40th batch. Thank you all for illuminating the occasion. Next, I respectfully invite the President of the Galle Medical Association, Professor Sampath Gunawardena, Professor of Physiology, Faculty of Medicine, University of Ruhuna, to address the gathering.
Very good evening to all of you. Chief guest, Professor M.D. Lamavansa, Vice Chancellor, University of Peradeniya, and Professor of Surgery, University of Peradeniya. Let me very warmly welcome you to the inauguration of the 80th Annual Academic Sessions of the Galle Medical Association. Orator, Professor Saroj Jayasinghe, Emeritus Professor of Medicine, University of Colombo, and Consultant for the Department of Medicine of the newly established Faculty of Medicine of the Sabaragama University of Sri Lanka. Let me warmly welcome you also to this very important event of the Galle Medical Association, sir. Past presidents of the Galle Medical Association, Vice Chancellor, University of Ruhuna, Dean, Faculty of Medicine, University of Ruhuna. Directors of Teaching Hospital Karapitiya and Mahamodara, consultants of the Teaching Hospital Karapitiya and Mahamodara, executive committee members of the Galle Medical Association, administrative staff of the Faculty of Medicine, members of the Galle Medical Association, other distinguished invitees, and dear medical students. As the President of the Galle Medical Association, I welcome all of you very warmly to this most important annual event of the Galle Medical Association. I do value your presence here despite your very busy schedules. Due to the COVID-19 pandemic ravaging in the country, GMA had to adjust to the situation and decided to hold this event as a virtual event for the first time in its history. We had to make a lot of adjustments, make a lot of decisions, and we had to ask a lot from the resource persons too. They had to do their presentations early and pre-record them. A lot of email communications took place. Although the secretary will deliver the vote of thanks at the end, I feel obliged that I must thank everybody involved for their fullest cooperation and support given to make this event a success. I believe it is my duty to take you briefly through the history of Galle Medical Association and its current activities. Galle Clinical Society, the predecessor of the Galle Medical Association, was established in 1940. That means this had been in existence for 81 years and is probably the second oldest medical association in Sri Lanka, being second only to SLMA. In 1993, Galle Clinical Society was transformed into Galle Medical Association. The last president of the Galle Clinical Society was Dr. D.S. Liyanarachi, and the first president of the association with the new name Galle Medical Association was Professor P.L. Ariyananda. From my medical student days, it is known to us that Galle Clinical Society was very active in its academic activities and social activities for its members. Some examples include holding discussions on different clinical topics and holding cricket matches with students, etc. With time, these activities have become more organized, and under the postgraduate directorate, GMA conducts Registrar Excellence Forum, Young Specialist Forum, and Wednesday Medicine Forum, etc. GMA had a good liaison with the PGIM for its library activities. From time to time, GMA holds webinars. We had 2 webinars on COVID-19 this year. From this year onwards, we started a new activity, Glimpse of Health in South, to enlighten the members on new investigations and treatment modalities available in goal. Further, we plan to conduct multidisciplinary clinical discussions starting from this year. This year, we managed to have doctors versus medical students cricket match in April. Unfortunately, we had to cancel the Aluth Arudu event. I think I failed in my duty if I do not mention few words on the GMA COVID fund. With the surge of hospital admissions in May this year, GMA decided to start a fund to help COVID care wards in Galle. We raised more than 1.1 million rupees and donated many items, including high flow oxygen delivery machine with humidifier, generator along with the wiring system, mattresses, furniture, UPS, sound systems, and many more needy items to COVID wards and the ICU. We continue to seek more donations and support the wards further. Ladies and gentlemen, the theme for the year and the academic sessions is sustaining healthcare amidst challenges. With the increasing ferocity of the COVID-19 pandemic, the theme became more relevant day by day. With ever increasing number of COVID hospital admissions, it has become a real challenge for our healthcare system to cater for these patients while maintaining routine healthcare services for other categories of patients. I'm sure other speakers, including the chief guest, orator, and the resource persons of the symposia on COVID-19 will talk on some of these challenges. Hence, I decided to talk on something that goes beyond the theme of these academic sessions in this latter half of the President's address. Being a physiologist with an interest on respiratory physiology, I thought of discussing the environmental changes and the quality of air and the possible effect of these changes on the humankind. The global environment is changing due to human activities over many centuries. Most rapid environmental changes started to happen probably after the Industrial Revolution. The first Industrial Revolution began in UK and spread to rest of the Europe and US from around 1760 to 1840, involving development of textile industry and steam engines. You may see that it has started in England and gradually spread across Europe. The second Industrial Revolution took place from around 1850 to 1917, mainly involving USA with the development of steel industry and automobile industry. You may note that there is a huge uncontrolled air pollution happening in and around these industrialized areas. Unfortunately, we all share one atmosphere. Due to air currents and weather systems, a pollutant produced in one place may reach faraway places. In this slide, it is apparent that there was a massive air pollution in New Delhi around 2019, which has probably made the air quality of Colombo also bad. Few words about the greenhouse effect, which can lead to global warming. With the Industrial Revolution, carbon dioxide levels in the atmosphere rose from 280 parts per million to 400 parts per million. Similarly, another greenhouse gas, methane levels, rose more than doubled. Cattle industry may be responsible for this, as a cow produces about 70 to 120 kilograms of methane per year, which has greenhouse effect equal to the amount of carbon dioxide produced by burning 1,000 liters of petrol per year. Now, you may start wondering which is better, to drive around in a bullock cart or a petrol vehicle. This is a diagrammatic representation of how much methane is produced by a cow. From a Western cattle, it is about 120 kilograms per year. When we hear about warfare, we tend to think about human life lost and destruction to property. We never discuss the environmental pollution it causes. We have missiles and missile defense systems or anti-missile batteries. When these get activated, they fire a series of anti-missiles to intercept the incoming missile. Although very spectacular, they produce large amount of heat and chemicals. These are shown to contribute to global warming. This shows what happens when global warming occurs. End of a glacier in Iceland. Global warming also resulted in melting of ice in Greenland and Antarctica. This melting ice causes rising sea levels and changes in weather patterns. Humans began reaching the space in 1957 when Soviet Russia launched the Sputnik 1 satellite. Ever since, there are thousands of rockets reached the space for various purposes like satellite launches to crewed spacecrafts. Each time a spacecraft goes to space, it goes through the stratosphere where the protective ozone layer is located. Rockets use supercooled methane and liquid oxygen as fuel. They directly release substances which can damage the ozone layer. Now, with businessmen eyeing space tourism, the damage to the ozone layer may become accelerated. Even fighter jets travel above the ozone layer. With the depletion of ozone layer, we lose the protection it offers from UV rays. Let me tell you a few words about air quality index. This measures 5 pollutants and convert it to a number ranging from 0 to 500. Depending on the number, air quality is classified in a range from good to hazardous, along with a color coding. Recent numbers from Beijing, New Delhi, and Colombo show that air quality index is hazardous in Beijing and New Delhi, while in Colombo it is unhealthy. Couple of years ago, it was shown that in New Delhi, the air pollution is due to burning farmlands after harvesting and also due to lighting firecrackers for Deepavali, all man-made pollutions. Dear colleagues, I have taken you through some facts that we may not think about usually. With all these man-made problems, we may end up running into healthcare issues in the future, probably of unimaginable magnitude. These include various respiratory system related diseases, cancers of skin and elsewhere, natural disasters, etc. Unless we think about these man-made issues now and start remedying them now, we may end up in a catastrophe much more severe than COVID-19 pandemic. I must thank the audience for listening patiently. My special thank goes to the chief guest and the orator for embracing this occasion. I must thank the GMA committee, especially the co-secretaries, editors, and others who contributed in making this event a success. I must thank my wife Vajira and my daughter Anjali for bearing with me during the lead up to this event. Thank you very much.
Thank you very much, sir, for your thought-provoking speech. Next in line is the keynote address. I respectfully invite the President, GMA 2021, Professor Sampath Gunawardena, to introduce the keynote speaker to the audience.
I consider it an honor and privilege to introduce the chief guest of the inauguration ceremony of the 80th Annual Academic Sessions of the Gold Medical Association, Professor M.D. Lamavansa, the Vice Chancellor of the University of Peradeniya and the Professor of Surgery, Faculty of Medicine, University of Peradeniya. He also serves as a general and pediatric transplant surgeon at the Teaching Hospital, Peradeniya. Until few weeks ago, he served as the Sri Lankan ambassador to the Russian Federation, concurrently accredited to Armenia, Belarus, Moldova, and Uzbekistan. He is currently the president of the SARC Surgical Care Society also. Professor Lamavansa has obtained his MBBS degree with a second-class honors from the Faculty of Medicine, University of Ruhuna. His professional and postgraduate qualifications include MS General Surgery from University of Colombo, PhD from University of Western Australia, and FRCS Edinburgh. He has honorary fellowships from the Association of Surgeons of India, College of Surgeons of Sri Lanka, College of Physicians and Surgeons of Pakistan, and Association of Minimal Access Surgery of India. He has held many important administrative posts in the past. He was the founder dean of the Faculty of Medicine, Wayamba University of Sri Lanka in 2018-2019 period. He was the Dean, Faculty of Medicine, University of Peradeniya from 2012 to 2015. In addition, he was the head of Department of Surgery and the founder head Department of Nursing in the University of Peradeniya. Professor Lamavansa was a past president of the College of Surgeons and served as the secretary of the College of Surgeons for 4 years. In addition, he has served as a member of many nationally and internationally recognized committees. Further, he served as an examiner for PGIM as well as many foreign postgraduate examinations in surgery. He has 20 publications in peer-reviewed journals and over 75 abstracts to his credit. Sir, it is an honor to have a person with such a vast experience as the chief guest of the 80th Annual Academic Sessions of the Gold Medical Association. Let me cordially invite you to deliver the keynote address this evening. Over to you, sir.
A very good day to all of you. Professor Sampath Gunawardena, President of the Gold Medical Association, past presidents, council members, Orator Emeritus Professor Saroj Jayasinghe, Vice Chancellor, University of Ruhuna, Senior Professor Sujiva Amarasena, Dean Faculty of Medicine, Professor Vasantha Devasiri, Dr. Shelton Pereira, the Director of the Teaching Hospital Karapitiya, Dr. T.B. Vimalasena, Director, Teaching Hospital Mahamodara, friends, ladies and gentlemen. It is a singular honor bestowed on me to have been invited as the chief guest at the inauguration of the 80th Annual Academic Sessions of the Gold Medical Association. Especially so as I am the first graduate, as I understand, from the Faculty of Medicine Gold to have received this honor. As a student of the second batch of Ruhuna, I have benefited immensely from the vibrant evening discussions conducted by the Gold Clinical Society, the forerunner of the Gold Medical Association, initially at Mahamodara Hospital and thereafter at the Karapitiya premises. Since then, I have witnessed, although from a distance, the transformation of Gold Clinical Society into a very active medical association under the able medical fraternity, some of whom are the greatest medical teachers and practitioners of our time. Rather than talking on a medical topic, I decided to choose a theme on which we tend to think that we know, but by and large poorly understood or practiced. The topic, seeing problems from different perspectives, can we do better? If this is rephrased slightly, it would read as trying to understand the perspective of others in one's day-to-day personal and professional lives, and it is called perspective taking. Why did I select this theme? Decision to choose this theme is strongly related to the ethos required in my previous job, without which I would have blundered as a diplomat, and now equally or more importantly, to interact with well-groomed academics of different sizes and shapes, numbering over 1,200 and over 2,400 non-academics, 40,000 and 14,000 undergraduates, 4,000 postgraduates, and several other stakeholder groups, including those intrusive into university lands. I'm making some valiant effort in my present job to be successful in perspective taking, despite being a surgeon. Perspective taking can be further described as not only the ability to understand how a situation appears to another person, but also as how that person is reacting cognitively and emotionally to the situation. The following quote by an American investor philanthropist, Charlie Munger, I quote, "I never allow myself to have an opinion on anything that I don't know the other side's argument better than they do, highlights the need to understand the other better than they do." A great example of different viewpoints is an actual view of an object from a different perspective. Let me quote from a children's book, a story about two porcelain cats sitting on a shelf. There was a rubber ball between them. The ball was half red and half blue. Each of the kittens could see only one side of the ball. They argued all day long about the color of the ball. One said it was red and the other that the ball was blue. They got so angry that the shelf started shaking. Both porcelain kittens fell off the shelf and shattered on the floor below. Objectively, they were both wrong and did not see reality as it was. Both kittens were right in their bubble. They just did not see the whole picture and in the end destroyed them. This type of disruption is not confined to porcelain kittens, seen unfortunately among the elite professionals too. Two ideas that we can take from this are, if the other person is strongly in favor of a point you can't see, maybe there is a reason for it. You don't have to prove your point. You have to understand that their way to bridge the gap. Another example in day-to-day encounter is news. There are inherent biases in the news they telecast or publish. Therefore, some viewers switch between TV news channels to get different perspectives more or less equally. Studies have linked lack of perspective taken to social dysfunction and aggressive behavior. Lack of perspective taking makes a person act in ways that are not considerate to other people in day-to-day life, making crucial decisions on behalf of others, revealing certain information about a person without their permission, insisting on your own flavors without considering other people's preferences, etc. When conflict arises and parties are unable to see things from each other's point of view, sometimes the fate of the relationship hangs on a thin thread. Psychology tells us that we start to develop this ability from a young age and then throughout our adult life. However, we need to consciously apply this skill in our daily activities and interactions if we were to do well. But it is not easy. The process is gradual and requires abundance of hard work. The good news, however, is that with practice, our skills improve. As we reach positive outcomes, we become more and more motivated to put in some more effort. We are hardwired to self-preserve. Our mind will first view things in ways that will soothe us and make decisions that will preserve us. It is also important to acknowledge that our brains are wired to egocentric anchoring and adjustment. In other words, the very organ that we use to make sense of our world places us at the center of the world. It makes us the heroes and gives others only supporting roles. This phenomenon explains why we immediately refer to our own experiences, opinions, and perspectives and use I more often than required as our base point. Thereby, we choose the most comforting or the easiest point of view. For example, it may be easier to conclude that a colleague we dislike for some reason or another was sacked for his or her poor performances at work than promoted for nonsense attitude at work. Translating this to the university administration, it may be easier for university students to conclude that their VC or deans or proctors are strict and inconsiderate because they refuse to allow them to go on trips without prior permission. They fail to understand, however, that it was caring attitude and the worry for their safety and have been a regular requirement to do so. In perspective taking, however, we need to move away from this egocentric starting point. We as medical men and women listen to different perspectives in our professional lives. Complex clinical problems are solved on trying to understand the perspectives of the others. As students in GOL, we had the first-hand experience of perspective taking, although we did not jargonize our experience like what I am trying to do today. In one of the evening sessions of the GOL Clinical Society, then I can well remember the senior consultants discussing the management of a middle-aged man presented with a neck node without any other symptoms. The mild-mannered ENT surgeon in charge of the patient was searching through all the holes of the upper body for a cause of lymphadenopathy, and the clinically aggressive general surgeon's perspective was to bias the damn thing, which would enable localizing the origin of the enlargement to a particular set of organs or organs. Mind you, this is time when we did not have fine needle aspirations, ultrasounds, or CT. There is no perfect way, but the conscious attempt to understand another's point of view can build new neural pathways, create real learning, and reshape interactions. Without losing its name, giving another name to psychology tells us that we start to develop this ability from a young age and throughout our adult life. However, we need to consciously apply this skill in our daily activities and interactions if we were to do well. But it's not easy. The process is gradual and requires abundance of hard work. The good news, however, is that with practice, our skills improve. As we reach positive outcomes, we become more and more motivated to put in effort. We are hardwired to self-preserve. Our minds will first view things in ways that will soothe us and make decisions that will preserve us. It is also important to acknowledge that our brains are hardwired to egocentric, anchoring, and adjustments. In other words, the very organ that we use to make sense of our world places us at the center of the world. It makes us the heroes and gives the others only supporting roles. This phenomenon explains why we immediately refer to our own experiences, opinions, and perspectives and use I more often than required as our base point. Thereby, we choose the most comforting or the easiest point of view. For example, it may be easier to conclude that a colleague we dislike was sacked for his or her poor performances at work than promoted for no-nonsense attitude at work. In another example, close to my present job, it may be easier for university students to conclude that their VC, deans, or proctors are strict and inconsiderate because they refuse to allow the students to go on trips without permission. However, they fail to understand that it was caring attitude and the worry for their safety and being a regulatory requirement. We as medical men and women listen to different perspectives in our professional lives. Complex clinical problems are solved on trying to understand the perspective of the others. As students in Gaul, we had the first-hand experience of perspective taking, although we did not diagnose our experiences like what I'm trying to do today. In one of the evening sessions of the Gaul Clinical Society, I can well remember the senior consultants discussing the management of a middle-aged man presented with a neck note without any other symptoms. The mild-mannered ENT surgeon in charge of the patient was searching through all the holes of the upper body for a cause of lymphadenopathy, and the clinically aggressive general surgeon's perspective was to biopsy the damn thing, as he expressed, which would enable localizing the origin of the enlargement to a particular set of organs or organ. Mind you, this was a time when we did not have fine needle aspirations, ultrasound, or CT. There is no way to perfect perspective taking skills, but the conscious attempt to understand another's point of view can build new neural pathways, create real learning, and reshape interactions. Without losing its meaning, giving another name to the issue at hand can generate new connections and help unblock what was previously stuck. For example, an organization which is faced with high staff turnover, the problem could be renamed from the original question, is it high staff turnover that is affecting the business, or rather the retention difficulties? Problems can be seen from the core outwards. Are you trying to prevent something from happening? How about going for the opposite reaction? Let's say you need to de-incentivize a specific behavior of your employees. For instance, reduce productivity. Shall we say particular university division derived from poor attitude of workers, absenteeism, and so on. Perhaps as opposed to imposing punishments, which could eventually lead to overall dissatisfaction, one might go ahead and incentivize higher performance. Solutions are often two-way street. What some may regard as a solution may be the initial root of the problem for the others, and vice versa. Considering a wider frame of views has the potential to generate previously unseen perspectives and resolutions. Understanding how a specific decision could affect others is key to understanding its full extent. If what apparently came off as a major inconvenience to some may turns out to be highly beneficial for others. So it may well be worth considering incurring it as an expense. It might be worth trying to compartmentalize the problems into small elements. Dealing with one piece of the issue at a time will help ease the workload and in turn help speed things up. Mathematicians use this in their day-to-day work. If everything else fails, trying to run the problems through circles outside the issue at hand could work. A fresh, new perspective into the matter is bound to shake things up just enough to clear the fog. Bringing in people with other areas of expertise can complement the knowledge that's already on the table, providing with the final piece of the puzzle. Once, not long ago, I was perplexed with the behavior of one of the high-end academics of my staff. I decided to ignore the academic so that no more friction or adversaries could emanate. In passing, I mentioned this to another senior academic living these days in the United States, from whom I generally get advice. He said, "You have done no harm. You don't have any personal issues with him. Therefore, engage with him and try to understand him. The outcome has been beyond my expectation." Try going directly to the worst case scenario and moving from a perspective of defeat could prove the key to not only better navigate the issue, but rather to deconstruct it from its final expression backwards, right up to its origin. Any gain is a win. By illuminating the problem in a positive light, it is possible to realize that in spite of its many potential pitfalls, there can also be benefit to it. Sometimes the reward may surpass the initial damage, as I mentioned earlier. Let's just go back to the chaotic example of allied health sciences degree programs started way back in 2006-2008 period. There were gross misunderstandings. Despite promising benefits, different perspectives among stakeholders led to a chaotic situation in the country. We failed to arrive at a compromise solution, and consequently, we, wearing white overcoats and gowns, surrendered our opportunity to take decision to those wearing black robes. Training in perspective-taking skills requires some level of observation, comparison, discovery, deducing, communication, interaction, and even meditation. Not many people will readily do such just to get another point of view. It is mentally heavy and discomforting. For example, a person that has never been poor or discriminated against might find it difficult to see or understand the perspective of people in that situation. And also, sometimes we fear that we might have to forego our own perspective in adapting someone else's. Adapting a different perspective can sometimes be difficult, as accepting that one's view as wrong is emotionally discomforting as well. Imagine if in a non-progressive situation, you were able to pause, take a deep breath, and try to imagine things from their point of view. Then through understanding and effort, you could have a fruitful discussion instead of a heated argument. Using what the power or force, using whatever the power you have or force to bulldoze others is most destructive and never be constructive. The first step of perspective taking, we mindfully decide to set aside our own goals. Instead, we purposefully center the perspective of the other person. We let go our egos. We decide instead to engage with their lived experiences and the way they perceive the issues. If you can see the motivation behind the arguments on the other side, you will be better equipped to offer solutions that satisfy their needs. You do not have to agree with their point of view. You may think their position is wrong or stupid or both, but before you understand, you cannot work out the solutions. Through this process, we understand how others perceive the issue. In this step of ideate, we imagine several possibilities. We work through the common obstacles to perceive perspective taking. Then we navigate around them to see the other person clearly and imagine how they might be thinking about the situation. These are assumptions. They may not be the truth, but they are as close as we can get. After hypothesizing, which is a light hypothesis, then we are ready to go for new information about the other person. Now we are ready to engage with them, observe and adjust our assumptions. We have an open discussion. We are curious and ready for insight. Were we able to connect and collaborate with them? If yes, then successful. If not, it's time to go deeper and further to challenge our assumptions. Whatever the outcome, the process of perspective taking isn't over. It is a constant cycle of empathy, imagination, estimation, and discovery. Stereotypes deprive us of adventures and curiosity. We cannot see anything new if we have concluded that a particular thing or a person in a certain way. Try and get to know people instead of believing common stereotypes about them. Ask questions and be curious. At this stage, I will relate what Professor Galkatia, another staff member of University of Peradeniya Department of Surgery, third batch Ruhuna, reminded me yesterday about a particular patient presented at the clinical meetings of World Clinical Society. Dr. Nihal Marker, an AST clinician, presented a patient with pyrexia of unknown origin. without any other discernible symptoms or signs. He had been heavily investigated with whatever the blood and urine tests available at the time, including a chest X-ray, and all of them have been repeated at least once, looking for any change over the period under observation to derive some clue to the cause of fever. Dr. Nihal Marcus said that, except the continuation of fever, which is supported with very long temperature charts, and gradual reduction of hemoglobin, he said, there is nothing to report, unfortunately. Dr. Panagam, senior lecturer in surgery, as promptly as possible, no wonder why the hemoglobin is dropping by looking at so much of blood tests you have done. And those are some of the things that we remember forever. Remember that the problems can be viewed from multiple perspectives. Your perspective, the other person's perspective, and the third party perspective. Whenever you are not sure about a situation, instead of assuming and concluding, it's important to seek clarity. If your partner has said something or acted in ways that call for alarm, withhold judgment, and ask them to explain what they said or their actions before concluding. A major step in developing your ability to see things from different perspectives is to withhold judgment and be slow to conclude. Even if you notice familiar patterns in a situation, do not conclude yet. Benefits of perspective taking are many. I will just only concentrate on the last item, the include leadership. Leadership is more than just directing people and watching them to do what you have suggested. Whether you are working with a team of handling customers, being able to anticipate their thoughts and interests is important. It helps you to be effective in your biddings and relationships. Perspective taking puts power in check. It enables leaders to see the value of other people aside from themselves. When leaders see value in other people, they are able to reach out to them, and this will earn them more respect and trust among their subordinates. People struggling with low self-esteem and self-worth may not know when and where to draw the line in perspective taking. They may get too worried about the people's point of view. This may result in feeling of self-doubt and insecurity. A person might lose their own perspective. While it is great to see things from different perspectives, learning to evaluate perspectives is as important. A different perspective does not necessarily mean that it is right and yours is wrong. Being flexible about is what is important. In order to start putting this skill to work, we need to motivate. Learning the skill to take perspectives means nothing if there is no propensity or intention to use it. Cultivating the desire to strengthen perspective taking muscle lies in recognizing the importance of it. Perspective taking is linked to the main skills of emotional intelligence, namely self-awareness, self-regulation, motivation, empathy, and social skills. I do not wish to make judgment on our ability as adults or medical professionals in perspective taking. However, suffice to say that I have met well-trained school children in this country and abroad who are better than us. The students who improve their perspective takings are better able to do many things, and they are certainly very well skilled in social matters and social interaction. As practicing medical professionals, when we carefully think of patient-centered communication, is nothing but centered on perspective taking. President of Gold Medical Association, ladies and gentlemen, I belong to a specific era of the history of the medical school in Gold. I saw then the close association between the faculty and the clinical society from which we harness many attributes embedded in us. I consider your invitation to me as a gesture to appreciate those pioneer students of GOL, and particularly the second batch. I believe we as a second batch has made justice to the faculty and the clinical environment from which we gain training by producing the highest number of consultants per batch as a percentage ever in the history of any faculty of medicine in Sri Lanka. 2/3 of my batchmates became consultants. 6 or 7 professors, presidents of several professional organizations at national and regional levels and international levels, 3 deans, served 3 different universities, established 2 new faculties in this country, 1 secretary to a ministry and major general, and 1 ambassador, and 2 incumbent vice chancellors, 1 seen the picture, the number 1 and the last one. Dear teachers from both sides across the road, you could not have asked more from us, the second batch. The beauty is, even though our teachers are retired, some like Lama, Pana, and Asoka and Ari, as we fondly call them, do not forget to send a line or give a call even now to congratulate our successors. Finally, the steadfast effort made to hold this year's conference, despite the current pandemic, is testimony to the GMA's commitment to its core functions. This year, under the leadership of Professor Sampath Gunawardena, and as a consequence of his meticulous attention to detail, I am most certain that you will experience a successful conference, notwithstanding the pandemic, and that you will therefore achieve a memorable year. Thank you very much indeed once again.
Thank you, sir, for your words of wisdom. Encouraging and appreciating professional achievements. Each year, the Gaul Medical Association presents numerous awards to its valued members. Next, I cordially invite the postgraduate coordinator, Dr. Ganaka Senaratne, consultant physician, Teaching Hospital Karapitiya, to announce the GMA Awards 2021.
Good evening, everyone. Young Specialist Forum of the Gaul Medical Association has been established to support our senior trainees for their professional development. So GMA has established this Young Specialist Forum about 3 years back, and it has been on action since then. Presentation skill development, foreign training familiarization, and communication skills development are some of the aspects that had been addressed at the Young Specialist Forum. Senior registrars across all the specialties are given an opportunity to make presentation of their own, where a panel of eminent judges assess them. In addition to the assessment and deciding the merit, each presenter is given a valuable personal feedback at the end, which really help them to improve. And the best presenter will be given the opportunity to present at our annual academic session each year. So year 2021, we had 5 such presentations made by all the senior registrars across all the specialties. Unfortunately, we had to postpone many of them because of the pandemic situation. Ladies and gentlemen, the winner of the Young Specialist Forum 2021 is Dr. Tarindu Eranga Kananka Hewa, Senior Registrar in Internal Medicine, attached to Ward 3435, for his presentation on Stethoscope of the 21st Century. Are you ready for the new era in medicine? Please welcome Dr. Tarindu Eranga Kananka Hewa. We had selected 2 other presenters for the merit certificate. First merit certificate is awarded to Dr. Pratibha Kayavasa, Senior Registrar of Pediatrics, for her presentation on obstructive sleep apnea in children, a diagnostic challenge to the children. Please Please welcome Dr. Pratibha. Second merit certificate is awarded to Dr. Sahan Mendis, Senior Registrar in Internal Medicine attached to Professorial Medical Unit and Lecturer in Pharmacology in Department of Pharmacology, Faculty of Medicine, for his presentation on To Kill or to Cure a Prescriber's Jealousy. Please welcome Dr. Sahan Mendis. World Medical Association wishes all the very best to all our presenters in their future endeavors. Now it's time to present the winner of the best presentation in clinical medicine, selected from registrars in general medicine at the Wednesday postgraduate medicine meeting. The winner is Dr. Chetana Naomi Karunatilake, registrar in general medicine attached to Ward 3435. Ladies and gentlemen, we would like to again wish all the very best from the Postgraduate Directorate of World Medical Association to all the presenters who made their presentation at both these forums. Thank you very much.
Thank you, sir. The most prestigious event of an academic body is its oration. I respectfully invite President GMA 2021, Professor Sampath Gunawardena, to introduce the GMA Orator 2021 to the audience.
It is my pleasant duty to introduce the orator of the 80th Annual Academic Sessions of the Gold Medical Association, Professor Saroj Jayasinghe, Emeritus Professor of Medicine, University of Colombo. He currently works as a consultant to the Department of Medicine, Faculty of Medicine, Sabaragama University of Sri Lanka. He qualified with MBBS Honours from the Faculty of Medicine, University of Colombo, and has an MD Colombo, MD by thesis from the University of Bristol, and an MRCP UK. He is a Fellow of the Royal College of Physicians, London, the Ceylon College of Physicians, and the National Academy of Sciences of Sri Lanka. In 2016, he was awarded his third doctorate, a PhD by the University of Colombo, for his thesis on poverty, ill health, and social welfare policies, a study of the urban poor in Sri Lanka. He was a former chair professor of medicine, Faculty of Medicine, University of Colombo, and was one of the longest serving consultant physicians at the National Hospital of Sri Lanka until his retirement in 2021. He was the first director of Medical Education Development and Research Center, MEDAC, the academic director of the Health Development and Research Unit that conducts multidisciplinary courses with a focus on social determinants of health, and the founder head of Department of Medical Humanities, the first such department in Sri Lanka and in the region. He initiated the International Conference on Medical Humanities in 2018, the annual Colombo Medical Congress in 2020, and has held numerous positions in the faculty, the university, and at national and international levels. He is an invited member of the National Health Research Council and a member of the advisory board of the Center for Bioethics and Humanities of the International Medical University. He is a member of the editorial board of the Journal of Urban Health of the New York Academy of Sciences, the Ceylon Journal of Medical Sciences of the Faculty of Medicine, University of Colombo, and has over 150 publications in peer-reviewed journals and won several awards. His current interests include studies on kindness in healthcare workers, systems science, clinical reasoning, and urban health. During the past 18 months, he has conducted or collaborated in several projects related to COVID-19. These include describing the origins of the pandemic using systems approaches, working on mathematical models of the epidemic to predict its trajectory, descriptions of the clinical features of the disease, analyzing the ethical issues of the crisis, exploring controversial therapies including Ayurvedic preparations, hydroxychloroquine, and ivermectin, and development of medical devices to assess endothelial dysfunction. During the past 18 months, he has published 14 peer-reviewed papers on a wide range of topics in COVID-19 and advised numerous stakeholder groups and policymakers. Sir, we are honored and privileged to have an invited oration delivered by a person of your caliber. Let me cordially invite you to deliver the oration of the 80th Annual Academic Sessions of the Gold Medical Association.
Good evening, Chief Guest, Professor M.D. Lamavansa, Vice Chancellor, University of Perodenia, Guest of Honor and Guests of Honor, Professor Sujiba Amarasena, Vice Chancellor, University of Ruhuna, Dean, Professor Vasanta Devseti, Faculty of Medicine, University of Ruhuna, and Directors of the Teaching Hospitals of Karapitiya and Mahamodara. And Professor Sampath Gunawardena, President of the Gaul Medical Association, members of the Council, members of the Gaul Medical Association, the past, present, and future, distinguished invitees who are joining the event online. Firstly, let me thank the President and Council of the Gaul Medical Association for inviting me to deliver the prestigious Gaul Medical Association Oration 2021 virtually, which I consider a great honor and privilege. Since your beginnings as a Gaul Clinical Society in 1940, you have done a tremendous service to the profession and development of healthcare, both locally and nationally. My humble tribute to you. I have had the privilege of knowing the first president of the GMA, my dear friend, Professor P.L. Aryananda, and almost all subsequent presidents. I have also delivered invited lectures at previous GMA academic sessions of the University of Ruhuna, and have a publication in the very first issue of the Gaul Medical Journal at the time when my batchmate, Dr. Ruwan Ekanayaka, was the editor. My association with Gaul has a long history. Very briefly, my great-grandfather lived in Nagoda and pioneered sugar production. He was a key philanthropist of the Nagoda Royal National College. My late father, Mr. Donald Amarasiri Jayasinghe, was brought up at Nagoda and schooled in Richmond. I have fond childhood memories of making hundreds of visits to my ancestral home at Nagoda. So thank you once again for granting me this honor. The theme of the 80th Annual Academic Sessions is Sustaining Healthcare Amidst Challenges. I have therefore chosen a topic aligned to the theme, Sustaining Healthcare Amidst the COVID Challenge, an opportunity for scientists and academics. During the next 30 minutes or so, I will explore what this challenge is, what the opportunity we have as academics, scientists, and clinicians. And I hope to touch on clinical features, therapies, certain mental models or concepts we use, mathematical modeling, and some devices, all in relation to the COVID epidemic. I must also upfront state the conflicts of interest, and that relates to that I'm an advisor to one of the companies which are developing a device for endothelial dysfunction, which I want to describe during this oration. COVID-19 is an unprecedented pandemic, and unlike any previous pandemics, it's unfolding in real time, and we are seeing it happen through the social media. So it could be taken as a challenge which may overwhelm us, but I think we have a wonderful intellectual opportunity. For the first time, we are seeing it unfold, and we can be at the edge of knowledge because no one in this world is having special knowledge as regards to COVID-19. Everything is just 18 or 24 months old. So my suggestion and my earnest request is for academics to use this and ride this intellectual wave. Rather than getting drowned, use this and move along. See how it unfolds. See history in the making. Because this is something which we are not going to see again in the future. That is a new disease which is causing such a pandemic in a totally unprepared world. So now I would like to touch on some of the work which I have been involved in relation to clinical features and therapies. The clinical features were described in one of the papers I was a co-author in. It was at the initial stages of the epidemic, and where we looked at the clinical features basically and found that about 77% of persons who contract the infection are in fact asymptomatic. So that's something which is well known now and not of much relevance to the knowledge base at present. But what interested me more and recently was about silent hypoxia. And this is a topic I'm sure the current president, Professor Sampath Gunawardena, who did his PhD on vagal afferents in heart failure in relation to the lung, I'm sure he will find this fascinating. And this relates to this what we call silent hypoxia. As you all know, there is hypoxia or desaturation in patients who have COVID. And you would have seen some of the pictures in the social media of people collapsing. And that's because the hypoxia is silent. They do not have dyspnea, they do not feel ill, but their saturations are sometimes in the 70s, 60s, and then they suddenly collapse. Now, a bright young physician, Dr. Mahendra Ekanayaka from Homagama and Vatala, had looked at this very carefully. And what I'm going to say in the next few minutes is mainly his work, and I have been associated with that work, and we've just submitted a publication using his concepts. Now, there are certain phases of hypoxia which we can describe, and you can use exertional desaturation to detect hypoxia. That is, you exert and you see the hypoxia and the levels of desaturation. What he found was isolated post-exertion desaturation, which I will now describe. Now, if you look at COVID-19 is when this described here in the next few slides, how the virus enters the cell, and that's the cell of the epithelial cell, and causes an infection. And with that, you can have cytokines being released, or you can have microangiopathic vasculopathy, and you can have specific antibody developing. And this shows the 5 phases of this infection. So you have the infection in the upper airway, then it starts to shed, and it's detected on the swabs. This is during the incubation period. Once it starts to shed, you can detect it with the PCR. Then it's in the tracheobronchial tree, and then it's found in the bronchial tree. And finally, it's there invading the endothelial cells as well as the cells, the pneumocytes in the lung. And it's this invasion, this is the endothelium, and this invasion causes endothelial dysfunction. And that's where the mechanisms of thrombosis due to platelet activation and complement activation. This also causes vasoconstriction, fibrosis, and inflammation, and also a capillary leak with inflammation and subsequent exudation and so on. Now, the other interesting aspect is these thrombosis, microthrombi forming in different areas of the vasculature. So you have it in the pulmonary venular territory, as well as in the pulmonary arterial territory, and also in the capillaries. And you can see how these blockages, which will form, which will open up, which will form again, can lead to hypoxia. So it's a very dynamic process which is happening. Now, if you look at the pathophysiology of happy hypoxemia, you will see how the pathologies which I described begin or evolve over a period of time. So you have initially edema and atelectasis causing intrapulmonary shunting of air as well as blood. Then you have changes in the perfusion because the endothelial dysfunction and so on. Then the regulation of pulmonary vasculature is affected. And then you start to have intravascular microthrombi. And it's only with these pathologies that the saturation starts to drop. But the person is still not dyspneic. You become dyspneic only with reduced lung compliance and increase in dead space and so on, with carbon dioxide retention and so on. So this is the reason why people who go around walking at this stage, with exertion, their saturation drops and they can fall unconscious. So that happens fairly quickly, and that can happen even when a person walks from the hospital bed to the toilet. And that's key. And this can happen to people who are walking outside, and you have seen clips of videos where people have fallen dead in shopping malls. And that's because of the silent hypoxia. And this is critical because we need to educate the health professionals as well as the people that exertion can be deadly. So you get hypoxia without dyspnea because of all these reasons, right? Shunts, dysregulation, lung diffusion getting affected, formation of intravascular microthrombi. But you don't feel dyspneic because lung compliance is preserved. There is no increase in airway resistance. There are no bronchi. There's no increase in dead space. And furthermore, even the peripheral chemoreceptors might be desensitized. That could be even due to the virus having a direct effect. We know that the virus affects the sense of smell. So whether it affects the chemoreceptors. And what really happens then is that the respiratory center does not sense that there is a discomfort or an uncomfortable sensation of breathing. So you are not dyspneic. And you can have this sort of desaturation even with severe illness, and the person will not know. There won't be dyspnea. And unless you look carefully for the respiratory rate, you might not detect it. And this is the spectrum which we see, from asymptomatic to mild to moderate to severe and critical. Now, what Dr. Mahendra Ekanayaka highlighted will be shown in the next few slides. Now, if you are at rest and you do a standard exercise, and the standard exercise is seated to standing for 30 seconds, about 8 to 10 times you can do this. In a normal person or person with mild COVID, the saturation does not drop. So you in the rest stage, the 60 seconds you check, it's above 96. You do it during the exercise, there's nothing. After exercise, also there's no change. But as the pathology progresses, the saturation starts to drop. And if it is below 94, then you know that that's a danger sign, because that could indicate that you're bordering on severe COVID pneumonia. So, and then it's spontaneous. Once you stop exercise, it spontaneously comes back, right? Now, in a few, if you exercise more than 30 seconds, right? So at 30 seconds, there's no drop. But more than 30 seconds, the saturation starts to drop and it comes back to normal. Again, understandable. So you're having a situation where you need more exercise to drop your saturation. Now, what's interesting is he found that there is a group who don't have desaturation at rest. It's above 96, otherwise you won't do the test. Then for 30 seconds, you do the sit-up, sitting and standing. There is no drop. And if you observe for a few seconds, and you're supposed to observe for 90 seconds, because there's a lag period, and then it drops. Sometimes drops below 94. In his own words, this is a game changer, like similar to the identification of critical phase in dengue. And I agreed with him, because I think this is a very important early sign, or which could be an important early sign. And that's isolated post-exertion desaturation. And we looked at some of the cases he has seen, and this is now being replicated by the other authors here, Ananda Vijayvikrama and so on, and several respiratory physicians, even at Karapiti, I know, have had a look at this, and they all agree that this could be an important clinical test which we can do, and we have submitted this for publication. We hope it would get published soon. So that's in relation to clinical features, how a very simple clinical observation can be an important tool in our management. And that's an opportunity which was grabbed by Dr. Ekanayake. As regards to therapy also, there are several things which we could do. I was involved in organizing this trial among naval personnel, you may remember, where we had an epidemic in Valisara base camp, and we wanted to do a hydroxychloroquine post-exposure study. The protocol was published, the study was conducted, but unfortunately, the adverse publicity at that time against hydroxychloroquine meant that most of our subjects had not taken the drugs, and we couldn't really analyze the data. The other one was an idea which promoted by Dr. Abe Gunasekara, the GU surgeon, and of whether antimalarial drug diethyl carbamazine could be used. This was again early stages of the epidemic, and we did an extensive literature search, and we felt that diethyl carbamazine, at least we should think of doing in vitro studies to see whether there are effects on the immunology as well as antiviral properties. In more recent times, you would have heard the controversy regarding ivermectin, and I've submitted this paper on how we should be arriving at a decision whether to use ivermectin or not. And I feel that it's more than evidence-based medicine. We should be deciding this based on decision-making theories, such as multiple criteria decision-making theory. Anyway, these are some of the opportunities in therapy which I've grabbed during the last few months. Now, when it comes to concepts and mental models, it's important to realize that we will decide on our studies and the way we treat or manage a pandemic, depending on what we have in our mind as a concept or as a mental model. And I've tried to look at 3 areas. One is to explore system science on the origins of the pandemic. How did the virus and why did the virus begin to invade humans? The second point relates to the rapid spread. Why is it, or how is it, that it spread so widely, so rapidly? And what are the factors? What's the mental model we have? And finally, predict what's going to happen when one day COVID becomes endemic and it's with us. It becomes part of us. And there I've looked at rhizomatic thinking. So let me now go through these briefly. In system science, what we try to look at is how systems function, that is, how interrelated components will function and how they organize themselves. Let me explain. If you look at this flock of birds, none of the birds here know which way they're going. None of them are leaders in this. And none of them will know the shape of their flock. But through a simple set of interactions and rules, they are functioning as a whole. It functions as a system. It's self-organized. And that's what we mean by a system where an interacting and independent components function as an integrated whole. And you can use this when you try to describe, or you can use this conceptualization or mental model when you're talking of population health. So we use these principles of a systems approach to understand COVID-19. And this was published recently. And we looked at a very basic process. So the virus, which is there in the wild, has to infect animals which we consume or we come into contact with. So we have animal husbandry or the wet markets in China. And it's here that they interact with the humans. And when the humans come in contact, you can have local epidemics, or there may be epidemics in animals themselves. So far, we haven't had that, though there was a scare with the mink in Denmark, but we haven't had that. But in a future pandemic of another organism, this is a possibility. So it's only when these local epidemics converge and due to a number of factors that they will become a pandemic. So we looked at the social and political and environmental determinants of this. And this is shown in this slide. For example, the wet markets. Why do wet markets occur? Because of certain cultural factors. So if you want to tackle wet markets, you have to tackle the cultural factors, either through legislation or education or changing culture, so that behaviors will change. And these wet markets will no longer supply wild animals and have a wide mix of animals and animal products in an environment which promotes their spread. If you look at animal husbandry, factory farming, and we know that the number of animals now in captivity for food, for human food, probably is higher than all the other animals in nature. That's the sort of numbers we are talking of. And why do we have animal husbandry? Because of corporate interests, profit motive. So from birth to death, these animals do not leave their factory farm. They don't know what nature is. They are fed here. They breathe here. They are in an artificial environment, and then they are killed. So why is there corporate interest with such huge animal, such huge factory farms? Because of globalization. That's one reason. And why is there globalization? That's decided by global governance, which promotes trade between countries, which promotes reducing customs and duties and promotes interdependency. And one may even think of these to be determined to some extent by the neoliberal capitalist system, which pushes for a profit motive. So there are various ways of looking at it, and we came up with this fairly complex model, and you'll see this part about animal husbandry, which I described, and about wet markets, and you'll see similar things in other areas, deforestation due to population pressures, overcrowding due to population pressures, and so on. So in other words, we were trying to look at the macro factors which could have generated the pandemic, which could have started off the pandemic. And it's important to know, because if you're really thinking of having some effect here, you'll have to tackle, or at least begin to discuss, about the global issues that will promote spread, if we are thinking of preventing future pandemics. Now, the next area of interest to me was, why was there rapid spread? And now we will try to describe this in the fact that people are traveling, people are the world is converging, and so on. But I wanted to look at this connectivity from a systems approach, and came up with this concept of dynamic physical hyperconnectivity, which has been submitted for publication. Basically, it looks at these systems. Again, these are systems. So I've taken a very simple example here. Imagine there are systems, three systems: the vehicles which are moving around, the ships and the artifacts. You know that millions of cargo are moving around in the world every day. Then you have airlines, which are again shunting millions of people to different destinations across continents. Now imagine a system where the three systems which I mentioned, the vehicles, the artifacts, the ships, and the airlines, converge at a given stage. That is, you say you have a situation where there will be certain peaks and troughs in vehicle traffic. Similarly, there will be certain peaks in the transport of artifacts by ships. And you also have a similar situation with the airlines, because the increase in airline transport, for example, with the tourist season. So you can look at this, the systems in this way. Imagine Wuhan at the time when there were so many vehicles moving around, and the holiday season, which was transporting millions of people out of Wuhan, some of them traveling around the world because Wuhan was an international transport travel hub, and also its internal port transporting goods within China. Now, if all these converge, you will have a situation where the numbers, the spread can accelerate and spread all over the world. So it's again a mental model of looking at connectivity. We are using hyperconnectivity, which is a concept from the IT field. The hyperconnectivity is physical objects, either humans or artifacts, or people traveling in artifacts, and it's dynamic because it's changing. So if this concept is true, we should be looking at different ways of modeling it. And that paper also has been submitted for publication. Now, the third area of mental model is about rhizomatic thinking by Deleuze and Guattari, two French philosophers, who looked at culture, saying that culture spreads more like a rhizome rather than a tree. So a rhizome is where you have underneath the soil, you have multiple roots which are interconnected. There is no beginning or end in a rhizome. It spreads as if it's spreading on surface. And it can go into new areas, it can get interrupted, but it can retreat and it can spread again. And you will now see when COVID becomes endemic, that's the sort of picture we may get. It will spread, there'll be vaccines, then it will retreat, then there would be variants, it will spread again, and it will be like a mosaic. It will just go like the roots of a rhizome. So instead of talking of epidemic clusters, convergence of epidemic clusters, which we have in our mental model, we should be thinking of endemic rhizomes which will arise. This again has been submitted for publication and accepted for publication in World Futures. Now I get on to modeling. So I've now so far discussed about certain clinical features and then about certain mental models. And now let's get on to hardcore modeling of the epidemic. And initially we looked at the model used in Vietnam and Sri Lanka, because if you remember, Sri Lanka was very successful with the first wave. And if we did not tackle the first wave, we would have had a devastating epidemic. And most of us would be dead by now, because if there was no vaccine in sight, we didn't know about dexamethasone, we didn't know about masks. You may remember even the WHO was saying not to use masks at this stage. But we had a different model which we used, which Sri Lanka used. And this paper compared the success of the Sri Lankan model with what they did in Vietnam. We have been less successful with the second wave, and now we are having problems with the third wave, but that's something which is happening all over the world. So what do we do? Why do we do modeling? We do it because when we want to test a hypothesis in a controlled environment, we are able to bring in different factors and then ask ourselves this question: what if? Now, that's something which we can't do. If you have a model, we can say, what if the vaccination is 50%? What if the vaccination happens in 3 months, and so on. And for this, there are different types of models which we can use. And one of the easier models is the compartmental structure, the susceptible, infected, and recovered model, or the susceptible, exposed, infected, and recovered model. And I'm indebted to Professor Sanjeeva Pereira, the chair professor of mathematics, and who is heading the Center for Mathematical Modeling, for being party to these studies. So in the initial stages, we looked at different types of modeling. One was a phenomenological modeling, that is to look at the epidemic in these different countries and different areas and use the mathematical concepts to look at what's happening in Sri Lanka or predict what's happening. The second one was where we used the SYER, the compartment model, and also we looked at effectiveness of strategies to help control the outbreak. And all these have been published in the journals. Now, in a SYER model, it's very simple. You divide the population into compartments. So you have a group who are susceptible and they get exposed. Once they get exposed, a certain proportion gets infected. Out of those who get infected, a small proportion dies and a large proportion recover. Now, in Sri Lanka, it was different to other countries because this was mainly imported cases. But now this factor would be less important. Initially, it was imported cases which brought in susceptible people to Sri Lanka as well as brought in the infection. Now, you can further add to this. So the infected people can go into ICUs, and from the ICUs, a certain proportion will die. From the ICUs, a certain proportion will recover, or the infected people will also recover. So if you, in a concept-wise, you're using mathematical formulae, especially differential equations, for each of these. And then you combine all these and run your model. We found that the projected cases would increase depending on the time we imposed movement restrictions. The earlier you have movement restrictions, the less the numbers. So that's the sort of what if question we can ask with mathematical modeling, and again a fascinating area of work using secondary data. You're not collecting data, you're using publicly available data to develop your models. But you must remember that there is a lot of criticism about mathematical modeling because garbage in and garbage out. So if you do not have the correct assumptions, you will get results which are not reliable. And these have been critiqued in certain journals, excellent articles on the use and misuse of mathematical modeling. Now, I must also bring in these two examples because recently in the media, they were talking about the University of Washington model, heavily criticized because at the beginning, because this did not predict the course of the pandemic in the initial stages until it was refined later on. Similar problem happened with the Imperial College model, which again gave the sort of information which made certain policy decisions, which they found was ultimately not, it didn't really work well for the policies. Interestingly here too, this is a critique of the Imperial College model coming from the warfare command. That's how research is happening even in the military in those countries. So the possible solution to this is to develop something like a meta-analysis of models. So you have an ensemble model, that is, you use the different forecasts and combine them to develop your model for spread of COVID, and that's what is being used by CDC. So now let me get on to devices. Again, a fascinating area, because here the hypothesis is whether the endothelial dysfunction, which I described in the pulmonary vessels, is reflected in the peripheral vessels. And the whole concept was developed by Kirti Kodituakku, who is the CEO of Gendo Innovations. And the basis of it is twofold. One is you look at the waveform. The other is to see the waveform after reactive hyperemia. I'll describe these briefly. That's the waveform, and physiologists and medical people are quite familiar with this, how the systolic phase is there, the diastolic phase is there, and this is something which you see in the arterial and even up to the capillaries. And there is a dichrotic notch, which is due to reflection of the wave from resistance or from the branching, and that's the one which causes the dichrotic notch. So the resistance, the flow onto this side brings this wave, and the dichrotic notch is because of this resistance. So you will understand, if there is a change here due to endothelial dysfunction, the dichrotic notch will change shape. So that's used to measure endothelial dysfunction. That is by analyzing the pulse wave. And we look at various parameters of the wave, including this bit. But you can use all the other parameters to see the waveform. And you do this with the photoplethysmography, where there is infrared and it detects the blood flow, very similar to your pulse oximeter. The second method is reactive hyperemia. That is when you occlude the vessel and release it, there is nitric oxide and so on produced, and then there is a post-ischemic, post-occlusive reactive hyperemia. There's a lot of blood which comes and then it goes down. So here is the infrared image, thermal image, right? Cuff, you start to inflate, and then it becomes black almost because there's no blood moving there. Then you release it and there's a lot of blood, and you can measure this, the flow, the reactive hyperemia. This is just to show you the example, but you measure it in a different way. You use the, you occlude the arm and from the blood pressure apparatus, and then you can measure it at the fingertip or looking at the brachial artery. Here you are looking at it from the finger, and you will see if you monitor the blood flow using thermal monitoring. So you are using the fingertip temperature. The temperature will fall because vessels are, there is no blood flowing. And then once you release it, there is blood flowing again, and there is this reactive hyperemia. And these are measures, the angle and the extent of reactive hyperemia are all indicators of endothelial dysfunction. Now, what's unique about the innovation by Gendo, and I'm advising them, and it was one of my ideas to develop some instrument for endothelial dysfunction, and it combines both these. You use photoplethysmography as well as digital thermal monitoring. And this development happened when Mr. Kirti Kodituakku did this as a final year project. And I was with Dr. Angela De Silva from University of Moratuwa, helping him and gave the idea of using endothelial dysfunction. And he has gone to the extent of developing this, doing a pilot study, and also having a patent on the algorithms which are being used. So a pilot study has already been done, which shows that the proof of concept basically, and it's being published and it's been presented in the prestigious, this is a very prestigious conference, the IEE, the IEEE, and it's being presented this year. Now, what's interesting to COVID? Well, we thought whether endothelial dysfunction can be used as a novel method to predict severe COVID. And here also, these are medical students who joined with us to write this paper. They were doing an elective in Moratuwa from our faculty, and this paper was published on endothelial dysfunction in COVID. So right now, we are in the process of doing a study to look at it. So during the past 30 minutes or 40 minutes, I have looked at the disaster of COVID, which has given us a unique opportunity. And I urge you all to surf the wave. And I've described the wave I've surfed and looked at post-exertion desaturation, looked at certain conceptual areas, looked at certain mathematical modeling, and also about devices. I have also ventured to the area of ethics and humanities in relation to COVID, and I have about 12 to 13 publications right now on COVID in press or already published. So, ladies and gentlemen, President of the Gaul Medical Association and Council, let me once again thank you for giving me this opportunity and inviting me to deliver this prestigious oration. Finally, I wish to thank the Gaul Medical Association, but I must thank my parents, and that's my father and mother. Both of them are not with us anymore. And also the collaborators whom I have worked with, Dr. Mahendra Ekanayaka, Professor Sanjeeva Pereira, and Mr. Kirti Hodutuako. Thank you very much once again, and good evening to you. Thank you.
Thank you very much, sir, for your timely and insightful speech. Many hands were united to make this virtual conference a possibility under challenging circumstances. To appreciate and recognize the contributions, I cordially invite Joint Secretary, Gaul Medical Association, Dr. Upeksha Liyanage, Consultant Physician, Teaching Hospital, Karapitiya, to propose the vote of thanks this evening.
The Chief Guest, Professor M.D. Lamavansa, GMA Orator for year 2021, Emeritus Professor Saroj Jayasinghe, past presidents and the members of the Gaul Medical Association, invited guests, students, ladies and gentlemen. On behalf of the President and the Executive Committee of the Gaul Medical Association, it is my pleasure to propose the vote of thanks at the inauguration ceremony of the 80th Annual Academic Sessions. The Chief Guest, Professor M.D. Lamavansa, Vice Chancellor, University of Peradeniya, we wish to express our profound gratitude to you, sir, for sparing your valuable time to address us on this evening. Thank you very much, sir, for enlightening us on a timely topic. Orator of the 80th Annual Academic Sessions, Emeritus Professor Saroj Jayasinghe, we wish to thank you, sir, for accepting our invitation to share your priceless scientific work for this year's GMA oration. Senior Professor Sujiva Amarasena, Vice Chancellor, University of Ruhuna. Thank you, sir, for gracing this occasion. Professor Vasanta Devasiri, Dean, Faculty of Medicine, University of Ruhuna. So we value your encouragement and continuous support for GMA activities and also for permitting us to use the conference hall and its facilities. Thank you very much, sir. Dr. Shelton Pereira, Director Teaching Hospital Karapitiya, and Dr. T.B. Vimalasena, Director Teaching Hospital Mahamudara, thank you for gracing this occasion. We take this opportunity to thank all the guest speakers of the plenary lectures and symposia of academic sessions for all the efforts taken to share their knowledge with us. Our thanks should also go to the judges and reviewers of the free papers and posters, and also the chairpersons of all sessions of the academic program. We wish to thank the head of the Department of Community Medicine, Dr. Champa Vijayasinghe, and her staff for their kind cooperation extended in arranging venue for coordinating activities of the virtual session. Dr. Lalindi De Silva for taking the task of comparing all the inauguration ceremony and the academic sessions. The service you provide is invaluable. Our special thanks go to the group of medical students who will be taking part in the entertainment event tonight for their creativity and commitment. We must also thank Sureka Samanmali, Savitra Vijayasiri, and Nisansala Vikramasinghe, the management assistants of GMA, for their continuous support in organizing GMA activities. The members of the event management team, the International Institute of Knowledge Management, TICOM events, for the assistance given in the arrangements. We wish to thank our main sponsors, Roche Biotech, Sun Pharma, Cipla, AstraZeneca, and George Stewart Health for their generous contribution. We would also like to thank all the other sponsors for their contributions. There are so many of you, you have worked tirelessly behind the scene to make this occasion a success. We thank you all for the support given. Finally, we extend our thanks to all of you, ladies and gentlemen, for being here with us, adding glamour to this evening. Thank you. Have a pleasant evening.
Thank you, Madam. With this, we come to the end of this inauguration ceremony of the 80th Annual Academic Sessions of the GMA. It was indeed an evening well spent with accomplished dignitaries, imparting knowledge, and with much more to look forward to. The scientific sessions, which commence this afternoon, will continue again from tomorrow morning and will be broadcasted live. Please do join us via Zoom platform for a stimulating academic experience. Before we wind up for the day, let us enjoy this colorful performance by the medical students of the Faculty of Medicine, University of Ruhuna.
your alibi. 'Cause I've drawn regret from the truth of 1,000 lies. So let mercy come and wash away what I've done. Raise myself, rise up, right, I'll be good. Erase myself, let go. Tulagang hamayay kasate ila ay sobatang maruwi Naginairit ayay lamay na suyamay lotale Wanamay sugandayay petirena Tudulata matuyen tibidena Anasangalose penana meawan manayay Widena Apataine nitale magale apadi sagare Tunani anse pudina Ukayay subadamay Apataine nitale magale apadi sagare Tunani anse pudina Ukayay subadamay Ilambari sudu parviren yanadina kuda veva Turin turata hasarali rali terapena kalak kuda veva Ilambari sudu parviren yanadina kuda veva Turin turata hasarali rali terapena kalak kuda veva Udingalagi mohita kandugan sila sayuru mata medaveti Ninde kari diligatin tanga kadetahan Udingalagi mohita kandugan sila sayuru mata medaveti Bienmi kalli diligatin tanga sahan sila soen sanagi Nilambare sudu kalliren yanadina kudaveva Doindurite hasaralurali terapena kalak kudaveva Ilambare sudu kalliren yanadina kudaveva Doindurite hasaralurali terapena kalak kudaveva one love, one heart. Let's get together, feel alright. Let's get together, feel alright. Yeah, the children cry. Yeah, the children cry. Sing you thanks and praise to the Lord, and I will feel alright. So let's get together and feel alright. Whoa, 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 whoa. Let them all pass over dirty remarks. There is one question I really love to ask. Is there a place for the hopeless sinners who has hurt all intention to save his soul really? What about the one heart? What about let's get together and feel alright? Let's get together and feel alright.
ඉඩක් නොතියමු කඳුළු බිඳකට සිනාතවරමු රිදුම් දෙන හද පරාජිත සුසුමක හදක් නොව දහස් සුවහස් ජය හදක් වෙමු.
We have now come to the conclusion of the inauguration ceremony. Tomorrow's academic program will commence at 8 a.m. Thank you, ladies and gentlemen, and have a pleasant evening.